ក្តីស្រឡាញ់ចំពោះវិស័យទណ្ឌសាស្ត្រនិងវប្បធម៌ក្នុងការចែករំលែកវាកាត់មុខមាត់ថ្មីនិងចំធ្គាមលើកទី2ដែលបានរៀបចំឡើងដោយសមាគមគ្រូពេទ្យវាកាត់មុខមាត់និងចំធ្គាមកម្ពុជាក្នុងនាមជាអាដិតនិងនិស្សិតទណ្ឌសាស្ត្រចំពោះការចូលរួមក្នុងអង្គសន្និសីទមួយនេះយើងខ្ញុំក៏សូមថ្លែងអំណរអគុណចំពោះម្ចាស់ឧបត្ថម្ភសន្និសីទដែលមានដូចជា Diamond Sponsor MIS Import Export BNB Dental Implant Supply Gold Sponsor ដែលមានដូចជា DKS Cambodia Ltd Excellent Dental Supply QDS Quality Dental Supply Chilica Institute of Surgical Pathology Metronicam Neobioden Dental Supply Dynamic Distribution Global Dental Supply CamLab Bangkok Dental Supply Sandeth Distribution Cambodia Co Ltd Mega Life Science Pty Limited Co Family មានដូចខាងក្រោមកម្មវិធីបើកអង្គសន្និសីទដែលរួមមានការគោរពផ្ទៃជាតិនៃព្រះរាជាណាចក្រកម្ពុជាសន្ទរកថាស្វាគមន៍ដោយសាស្ត្រាចារ្យហងសមេតអតីតប្រធាននិង Vice Chairman នៃសមាគមគ្រូពេទ្យវះកាត់មុខមាត់និងឆ្អឹងគៀមកម្ពុជាសន្ទរកថាដោយអន្តរបណ្ឌិតឯកទេស Phan ប្រធានសមាគមគ្រូពេទ្យវះកាត់មុខមាត់និងឆ្អឹងគៀមកម្ពុជាសន្ទរកថាដោយឯកឧត្តមឯកអគ្គរដ្ឋទូតនៃប្រទេសអូស្ត្រាលី Pablo Kang ប្រចាំប្រទេសកម្ពុជាការបើកអង្គសន្និសីទដោយឯកឧត្តមតន្តបណ្ឌិតគឺបូរ៉ារ៉ាត់រដ្ឋលេខាធិការក្រសួងសុខាភិបាលនិងការថតរូបដូចជាអនុស្សាវរីយ៍វិសាអាហារសម្រន់ពេលព្រឹកនិងលើកប្រធានបទ Management of Jaw Fracture from Heart Operation ការធ្វើបទបង្ហាញដោយ Dr. Borarorth លើកប្រធានបទ Combination of Orthodontic and Surgical Management of Facial Deformity ការធ្វើបទបង្ហាញដោយសាស្ត្រាចារ្យឯកទេសហងសមេតលើកប្រធានបទ What can go wrong with dental implant tip and hint for preventing implant complication ការធ្វើបទបង្ហាញដោយតន្តបណ្ឌិត Peach លើកប្រធានបទ Oral Manifestation of Systemic Disease ជាចុងក្រោយគឺជាការស្រស់ស្រូបអាហារថ្ងៃត្រង់និងទស្សនាស្តង់ពិព័រណ៍ទណ្ឌសាស្ត្រ
Here is our morning session agenda. Salute the national anthem. Welcome remark by immediate past President of Cambodia, Association Oral and Maxillofacial Surgeon, and Vice Chairman of LOC by Professor Hang Samit. Speech by the President of Cambodia Association of Oral and Maxillofacial Surgeon by Dr. Phan. Speech by His Excellency Pablo Kang, Ambassador of Australia to the Kingdom of Cambodia. Opening speech by the Chairman of the LOC and Secretary for State for Health by His Excellency Dr. Oeurn Borarorth, Tea Break and Visit Trend Exhibition. Presentation by Dr. John Avier on the topic Management of Jaw Fracture from Past to Present. Presentation by Dr. Barbara Woodhouse on the topic Combined Orthodontic and Surgical Management of Facial Deformity. Presentation by Professor Dr. Hang Samit under the topic What can go wrong with dental implant, tips and hints for preventing implant complication. Presentation by Dr. Peace on the topic the oral manifestation, systemic disease connection, and the last one is lunch break.
ជាកិច្ចបន្ទាប់យើងសូមគោរពអញ្ជើញសិក្ខាកាមទាំងអស់សូមមេត្តាក្រោកឈរឡើងដើម្បីគោរពភ្លេងជាតិនៃព្រះរាជាណាចក្រកម្ពុជាសូមគោរពអញ្ជើញ
Next, I would like to kindly request
សូមមេត្តាសម្រួលអេរិយាបថ
Thank you. Please be seated.
បាទសូមគោរពអញ្ជើញតន្តបណ្ឌិតឯកទេស Phan ប្រធានសមាគមគ្រូពេទ្យវះកាត់មុខមាត់និងឆ្អឹងគៀមកម្ពុជាឡើងថ្លែងសន្ទរកថាស្វាគមន៍សូមគោរពអញ្ជើញ
Next, I would like to invite Dr. Phan, President of Cambodia Association of Oral and Maxillofacial Surgeon, to give a speech. Please welcome.
បាទនឹងជាគណៈកម្មការនៃការរៀបចំអង្គសន្និសីទឯកឧត្តមលោកជំទាវលោកសាស្ត្រាចារ្យលោកវិជ្ជបណ្ឌិតលោក តនបណ្ឌិតលោកស្រីអ្នកនាងកញ្ញាជាគណៈធិបតីអស់លោកស្រីអ្នកនាងកញ្ញានិងសិក្ខាកាមទាំងអស់ជាទីមេត្រីភ្ញៀវកិត្តិយសដែលអញ្ជើញមកពីអង្គការក្រៅនិងក្នុងរដ្ឋាភិបាលជាទីរាប់អានថ្ងៃនេះជាឱកាសដ៏កម្រនិងអធិបធម៌ក្រៃលែងដែលឯកឧត្តមលោកជំទាវលោកសាស្ត្រាចារ្យលោកវិជ្ជបណ្ឌិតរដ្ឋបណ្ឌិតលោកស្រីអ្នកនាងកញ្ញាបានអញ្ជើញចូលរួមជាគណៈអធិបតីក្នុងអង្គសន្និសីទស្ដីពីបច្ចេកវិទ្យាវះកាត់មុខមាត់ថ្លើមធ្លាមលើកទី2ក្រោមប្រធានបទការលើកកម្ពស់បច្ចេកវិទ្យាក្នុងការវះកាត់មុខមាត់ថ្លើមធ្លាមនៅក្នុងប្រទេសកម្ពុជាខ្ញុំសូមរំលឹកពីសារបានសង្ខេបនៃការបង្កើតសមាគមក្រុមគ្រូពេទ្យវះកាត់មុខមាត់កម្ពុជាសមាគមនេះចាប់បដិសន្ធិនៅខែតុលាឆ្នាំ2018ដែលត្រូវបានចុះឈ្មោះរដ្ឋបញ្ជីក្រសួងមហាផ្ទៃនៅថ្ងៃទី9ខែមិថុនាឆ្នាំ2020សូមបញ្ជាក់ថាការព្រួយបារម្ភគំនិតនិងការជ្រុំជ្រែងពីសំណាក់តនបណ្ឌិតឯកទេសពីប្រទេសអូស្ត្រាលីម៉ាឡេស៊ីញូហ្សេឡង់និងប្រទេសដទៃទៀតសូមថ្លែងអំណរគុណចំពោះការខិតខំប្រឹងប្រែងនិងការលះបង់ពេលវេលាថាមពលធនធានផ្ទាល់ដើម្បីដល់សមាគមយើងខ្ញុំសន្និសីទនៃបច្ចេកវិទ្យាវះកាត់មុខមាត់ថ្លើមធ្លាមលើកទី1បានប្រព្រឹត្តទៅយ៉ាងជោគជ័យនៅថ្ងៃទី6ខែតុលាឆ្នាំ2021តាមរយៈអនឡាញដែលមានសមាជិកចូលរួមជិត400នាក់ក្នុងកំឡុងពេលរាតត្បាត COVID-2019 នេះសម្ដែងឲ្យឃើញថាតនបែបកម្ពុជាស្វែងយល់នឹងការគ្រប់គ្រងនៅសមាគមវះកាត់មុខមាត់ថ្លើមធ្លាមកម្ពុជាច្រើនកកកដូចគ្នានេះដែរសន្និសីទលើកទី2នេះគឺមានសមាជិកក្នុងការចូលរួមគឺប្រហែលជា200នាក់ដោយឡែកសន្និសីទលើកទី2នេះគណៈកម្មការរៀបចំអង្គសន្និសីទបានសម្រិតសម្រាំងអញ្ជើញវាគ្មិនក្នុងនិងក្រៅប្រទេសដល់ល្បីដែលមានបទពិសោធន៍ដើម្បីចែករំលែកចំណេះដឹងថ្មីៗនិងបទពិសោធន៍វះកាត់ជាបទពិសោធន៍ល្អៗដល់សិក្ខាកាមយើងសិក្ខាកាមទាំងអស់គឺខិតខំប្រឹងប្រែងស្ដាប់និងកត់ត្រាយកចំណុចសំខាន់ដែលទាក់ទងនឹងការវះកាត់មុខមាត់ឆ្អឹងធ្លាមកុំឲ្យមានផលវិបាកដល់ការវះកាត់មុខមាត់ដែលកើតមានឡើងដល់អ្នកជំងឺរបស់យើងឆ្លៀតក្នុងឱកាសនេះដែរខ្ញុំសូមថ្លែងអំណរគុណដ៏ជ្រាលជ្រៅដល់វាគ្មិនជាតិនិងអន្តរជាតិដែលខិតខំចំណាយពេលវេលាដ៏មានតម្លៃដើម្បីរៀបចំធ្វើការបទបង្ហាញដ៏មានសារៈសំខាន់ចែករំលែកនៅបទពិសោធន៍ដល់សិក្ខាកាមយើងក៏ដូចជាប្រជាពលរដ្ឋកម្ពុជានិងចូលរួមចំណែកក្នុងការលើកស្ទួយវិស័យសុខាភិបាលកម្ពុជាទន្ទឹមនឹងនេះខ្ញុំសូមអរគុណដល់ក្រុមហ៊ុនផ្គត់ផ្គង់ឧបករណ៍បរិក្ខារតនប្រសាសន៍វិជ្ជសាស្ត្រដែលបានជួយឧបត្ថម្ភនិងគាំទ្រសមាគមក្នុងការរៀបចំសន្និសីទមួយនេះដែលមានចំនួន14ក្រុមហ៊ុនធំដូចជា OMS Cambodia BNB Dental Supply DKSA Dental Dynamic Uniden Excellent QDS Neo Bioden Camlab Global D Metronicam Clinica Laboratory Phan Sandeth Swiss យើងសូមធ្វើការកោតសរសើរផងដែរដល់សមាជិកសមាជិកានៃក្រុមប្រឹក្សាសមាគមគណៈកម្មាធិការរៀបចំអង្គនិស្សិតក្នុងពេលនឹងមានដូចជានិស្សិតបរិញ្ញាបត្រជាន់ខ្ពស់ផ្នែកឯកទេសវះកាត់មុខមាត់ឆ្អឹងធ្លាមនិងនិស្សិតបរិញ្ញាបត្រមួយចំនួនដែលបានលះបង់កម្លាំងកាយកម្លាំងចិត្តដើម្បីជួយរៀបចំឲ្យមានព្រឹត្តិការណ៍ប្រវត្តិសាស្ត្រនេះកើតមានឡើងដោយរលូននិងមានកិត្តិស័ព្ទក្នុងវិស័យពិភពតនសាស្ត្រយើងក៏ដូចជាវិស័យសុខាភិបាលទាំងមូលជាបញ្ចប់ខ្ញុំសូមថ្លែងអំណរគុណដល់គណៈអធិបតីភ្ញៀវកិត្តិយសនិងអន្តរជាតិលោកស្រីនាងកញ្ញានិងសិក្ខាកាមទាំងអស់សូមមានសុខភាពបរិបូរណ៍និងថាមពលមាំមួនប្រាជ្ញាជ្រាលវៃសម្រាប់ចតាតាមទិសដៅនិងគោលបំណងគ្រប់គ្នាខ្ញុំសូមនិយាយជាភាសាអង់គ្លេសតិចដោយសារតែអគ្គរដ្ឋទូតអូស្ត្រាលីគាត់អញ្ជើញមកខ្ញុំបានប្រាប់ Now I would like to speak a little bit English with what we have been saying for the summary. I would like to sincerely thank you to Excellency Pablo Kang, the Australian ambassador in Phnom Penh, who spent a valuable time to attend the second symposium oral maxillofacial surgery in Cambodia. My deepest gratitude goes to speaker who has contentedly agreed to share their knowledge and experience, especially the Australian surgeon and the volunteer Barbara Woodhouse and John Avier from Australian and New Zealand Association for Oral Maxillofacial Surgery, who always contribute and commit to help and support our oral and maxillofacial surgery in Cambodia. It is a part of human resource development and also improve the healthcare system in Cambodia. I would like also to thank you for all of you like sponsor, and I hope all the participants has a pleasant and a memorable experience and enjoy the scientific session. Your attendance and support would be greatly appreciated. Wishing you a good health and happiness. Thank you so much.
សូមអរគុណសម្រាប់ការអធិប្បាយចំពោះការផ្សាយសម្រាប់កថាដ៏មានអត្ថន័យ
Thank you, Doctor, for your meaningful speech.
ជាកិច្ចបន្ទាប់សូមសូមក្រុមអញ្ជើញឯកឧត្តមឯកអគ្គរដ្ឋទូត Pablo Kang នៃប្រទេសអូស្ត្រាលីប្រចាំប្រទេសកម្ពុជាឡើងថ្លែងសន្ទរកថាសូមក្រុមអញ្ជើញ
Yes, I would like to invite His Excellency Pablo Kang, Ambassador of Australia to Kingdom of Cambodia, to give a speech. Please welcome.
Song group I can on you log slide and the Kanya you get your tango Chong Lip Su and Yong Kanya Song Rap Gan Jem Tani to His Excellency Dr. Borarorth, the Secretary of State at the Ministry of Health and Chairman of the Cambodian Association for Oral and Maxillofacial Surgeons, Excellency Dr. Sandeth, President of the Association, Doctors John Avier and Barbara Woodhouse and their team from Australia, distinguished guests, ladies and gentlemen. Thank you very much for reaching out to invite me to the opening of your first face-to-face symposium of oral and maxillofacial surgery here in Phnom Penh. And congratulations for being able to convene this event over the next 2 days, and also for establishing the first symposium online during the height of COVID-19. I don't profess to know much about oral and maxillofacial surgery, to be honest. But what I do know is this. Every day in my role, I'm privileged not only to participate in events or talk to recipients who have been the beneficiaries of Australian government support here in Cambodia, but also to meet so many Australians doing great work in Cambodia, donating their own time and resources, motivated by their own beliefs in the justness. So I want to thank Doctors Avier and Woodhouse and the team of volunteer surgeons from Australia whom they lead for devoting so much of their own energy into helping the good people of Cambodia. While the Australian government is not directly involved in supporting the oral and maxillofacial surgery sector here, we do of course have a long track record of support to the broader health sector in Cambodia, stretching over more than 2 decades. Just last week, I joined with the Minister of Health, Professor Eng, and development partners from the World Bank, Germany, the Republic of Korea, and the Global Financing Facility to announce a further 30 million Australian dollars towards the next phase of the Health Equity and Quality Improvement Project, which plays a vital role across the country in strengthening Cambodia's public health system and providing incentives for health centres and hospitals nationwide to improve their performance. I have visited numerous hospitals and health centres in places such as Pailin, Barabong, Kroche, Preveng and Mondulkiri to see this support in person. UNICEF during COVID donated some 2.83 million doses of the Pfizer BioNTech COVID-19 vaccine to Cambodia. We also provided 133 ultra-cold freezers for their storage, as well as training for health workers and awareness-raising materials for the general public. Most of our vaccines arrived just as the Omicron variant arrived in Cambodia late last year. Australia's Pfizer vaccine donations were rolled out immediately to frontline health workers and vulnerable groups, and I was pleased to see these vaccinations in person in Ratanakiri province earlier this year. The Australian government also supports a number of international Australian and Cambodian civil society organisations working in Cambodia on issues such as paediatric ophthalmology, preventable blindness, HIV/AIDS treatment, physical rehabilitation, and psychosocial counselling. So, whether it be the tireless work of volunteer surgeons from Australia in sectors such as oral and maxillofacial surgery, or programs in the broader health sector funded by the Australian government, I remain very proud of Australia's ongoing contributions to the well-being of the people of Cambodia, and I thank you again for inviting me here today, and I want to wish everyone present over the course of the next 2 days a very good series of learnings and discussions, and may you all also receive the four Buddhist blessings of Ayub, Vana, Soka, Nagolia, combined clean Lai.
Thank you, His Excellency, for your beautiful speech.
សូមអរគុណឯកឧត្តមឯកអគ្គនាយកអញ្ជើញ
Without further ado, I would like to invite His Excellency Dr. Oeurn Borarorth, Secretary of State for Health and Chairman of LOC, to give an opening speech. Please welcome.
អរុនសុស្ដីអរលោកស្រីទាំងអស់ជាបឋមសូមរួមឯកឧត្តម Pablo Kang ឯកឧត្តមរដ្ឋទូតអូស្ត្រាលីប្រចាំប្រទេសកម្ពុជាឯកឧត្តមលោកទាវលោកសាស្ត្រាចារ្យតមរិទ្ធនិងបងប្អូននិស្សិតទាំងអស់ជាទីមេត្រីថ្ងៃនេះតាមនាមឯកឧត្តមសាស្ត្រាចារ្យមកនេះរដ្ឋមន្ត្រីក្រសួងសុខាភិបាលក្នុងមានកិត្តិយសនិងសេចក្តីសោមនស្សរីករាយជាខ្លាំងត្រូវបានអញ្ជើញជាគណៈអធិបតីក្នុងពិធីបើកអង្គសន្និសីទថ្នាក់អន្តរជាតិស្តីពីបច្ចេកវិទ្យាវះកាត់មុខមាត់និងឆ្លងធានលើកទី2ដែលរៀបចំឡើងដោយសមាគមគ្រូពេទ្យវះកាត់មុខមាត់ឆ្លងធានកម្ពុជាទោះបីស្ថិតនៅក្នុងការរៀបបានៃជំងឺ COVID-19 ក៏ដោយក៏គណៈកម្មការរៀបចំសន្និសីទបានពុះពៀរាល់ឧបសគ្គនិងព្យាយាមអស់ពីកម្លាំងកាយកម្លាំងចិត្តដើម្បីរៀបចំសន្និសីទនេះដែលជាផ្នែកមួយនៃការបណ្ដុះបណ្ដាលសមស្របតាមនិយមនិងគោលការណ៍របស់ក្រសួងសុខាភិបាលក៏ដូចជាបទដ្ឋាននិងដែនកំណត់នៃគណៈកម្មការកម្ពុជាលោកតមដិតផាន់សាដេតប្រធានសមាគមវះកាត់មុខមាត់និងឆ្លងធានកម្ពុជាបានធ្វើបទបង្ហាញថាបច្ចេកវិទ្យាវះកាត់មុខមាត់ឆ្លងធានគឺជាឯកទេសមួយក្នុងចំណោមវិស័យតនសាស្ត្រដែលទើបនឹងធ្វើការបណ្ដុះបណ្ដាលចាប់តាំងពីឆ្នាំ2012មកក៏ប៉ុន្តែចំនួនតមនិតឯកទេសផ្នែកមុខមាត់ឆ្លងធានមិនទាន់គ្រប់គ្រាន់ដើម្បីធ្វើការសង្គ្រោះបន្ទាន់និងព្យាបាលថែទាំអ្នកជំងឺបានគ្រប់គ្រាន់នៅឡើយហើយនេះទាមទារឲ្យតមនិតទូទៅនិស្សិតទាំងអស់ខិតខំបង្កើនសមត្ថភាពក្នុងការវះកាត់មុខមាត់និងឆ្លងធាននេះឲ្យបានកាន់តែប្រសើរឡើងដើម្បីអាចជួយសម្រួលដល់ការព្យាបាលនិងមានចំណេះដឹងគ្រប់គ្រាន់ក្នុងការបញ្ជូនអ្នកជំងឺដែលមានស្ថានភាពធ្ងន់ធ្ងរមកទាន់ដល់ឯកទេសបានទាន់ពេលវេលាក្នុងឱកាសនេះខ្ញុំសូមថ្លែងអរគុណដល់សាស្ត្រាចារ្យតន្តបណ្ឌិតផ្នែកឯកទេសវះកាត់មុខមាត់ឆ្លងធានអន្តរជាតិនិងជាតិដែលបានស្ម័គ្រចិត្តខិតខំអប់រំបង្ហាត់បង្ហាញដល់និស្សិតតាក្រោយអន្តរសាឲ្យបានខ្លាយជាតមរិទ្ធឯកទេសវះកាត់មុខមាត់និងឆ្លងធានប្រកបដោយសមត្ថភាពនិងទេពកោសល្យដែលអាចជួយព្យាបាលនិងថែទាំជំងឺដែលកំពុងត្រូវការគ្រូពេទ្យប្រភេទនេះជាចាំបាច់ខ្ញុំសូមសម្រាប់យកនៅវិធានបទល្អមកផ្សព្វផ្សាយដល់តមរិទ្ធនិងនិស្សិតរបស់យើងផងដែរជាឱកាសនេះតាមនាមឯកគណៈកម្មការរៀបចំសន្និសីទខ្ញុំសូមថ្លែងអំណរគុណយ៉ាងជ្រាលជ្រៅដល់ sponsor ទាំង14ដែលបានបរិច្ចាគថវិកាជួយឧបត្ថម្ភដល់ការរៀបចំសន្និសីទនេះឲ្យបានប្រព្រឹត្តទៅដោយជោគជ័យជាមួយនេះដែរក៏សូមថ្លែងអំណរគុណដល់បងប្អូននិស្សិតមួយនិងតនដិតវ័យក្មេងដែលទើបនឹងបញ្ចប់ការសិក្សានៅពេលនេះបានជួយរៀបចំសន្និសីទនេះ ឲ្យដំណើរការបានជោគជ័យជាទីបញ្ចប់តាមមានឲ្យឯកឧត្តមសាស្ត្រាចារ្យរដ្ឋមន្ត្រីក្រសួងសុខាភិបាលខ្ញុំសូមតាមជាដល់លោកសាស្ត្រាចារ្យតមដិតនិងបងប្អូននិស្សិតទាំងអស់ដែលបានចូលរួមក្នុងអង្គសន្និសីទនាថ្ងៃនេះសូមត្រង់តាមស្ដាប់និងព្យាយាមស្ដាប់និងសួរនៅចម្ងល់ទាំងឡាយដែលពាក់ព័ន្ធទៅនឹងចម្ងល់អ្វីដែលយើងបានឃើញពីការបទបង្ហាញដើម្បីជាបទពិសោធន៍យកមកអនុវត្តនិងផ្ដល់សេវាប្រកបដោយគុណភាពនិងប្រសិទ្ធភាពជូនប្រជាពលរដ្ឋហើយខ្ញុំសង្ឃឹមថាឆ្លងកាត់នៃអង្គសន្និសីទនេះនឹងបានដល់នៅបច្ចេកទេសថ្មីៗដែលវាគ្មិនដល់បីប្រកបដោយបទពិសោធន៍ពីអន្តរជាតិក៏ជាតិដល់អស់លោកលោកស្រីទាំងអស់យកទៅប្រកបនៅវិជ្ជាជីវៈដែលយើងមិនបានពេញអ្វីដែលយើងបានខ្វះខាតកន្លងមកអញ្ចឹងខ្ញុំគិតថាឆ្លងកាត់នៅថ្ងៃនេះយើងនឹងបាននៅបទពិសោធន៍ថ្មីៗយកមកបំពេញនៅសេវាព្យាបាលប្រកបដោយប្រសិទ្ធភាពនិងគុណភាពជូនប្រជាពលរដ្ឋហើយក្នុងយើងឯកឧត្តមរដ្ឋមន្ត្រីក៏សូមផ្ដល់ជាដល់ហើយសូមការបាត់ផ្សាយដល់បងអតីតប្រធានសមាគមក៏ដូចជាប្រធានសមាគមបច្ចុប្បន្នដែលខិតខំប្រឹងប្រែងរៀបចំឲ្យមានសន្និសីទនិងបានអញ្ជើញនៅវាមិនល្អដែលខ្ញុំសង្ឃឹមថានឹងបន្តិចទៀតនេះនឹងមានការបកបង្ហាញនៅប្រធានបទល្អដល់ជូនដល់ទៅអស់លោកជាសាស្ត្រាចារ្យបណ្ឌិតនិងនិស្សិតទាំងអស់ដើម្បីជាប្រយោជន៍ក្នុងការជួយព្យាបាលដល់ប្រជាជនយើងប្រកបដោយប្រសិទ្ធភាពបាទហើយជាទីបញ្ចប់ក៏សូមជូនពរដល់ឯកឧត្តមឯកឧត្តមទូតអស្ចារ្យប្រចាំកម្ពុជាឯកឧត្តមលោកវិទ្យាអស់លោកប្រសិទ្ធអស់ទទួលបាននូវពុទ្ធពរទាំង4ប្រការគឺអាយុវណ្ណៈសុខៈពលៈគង់បីជាទៅហើយសូមឱកាសបានអង្គសន្និសីទចាប់ពីពីតទៅសូមអរគុណ
បាទសូមអរគុណពីក្រុមការដែលសម្រាប់អង្គសាស្ត្រដ៏មានអត្ថន័យ
Thank you, His Excellency, for your meaningful
ឯ
speech.
កទេសផានសាន់ដេនៅកម្មវិធីការដើម្បីផ្ដល់ជូននៅវត្ថុអនុស្សាវរីយ៍និងបានផ្កាជូនដល់ឯកឧត្តមតនតបណ្ឌិតអឿនបូរ៉ារតរដ្ឋលេខាធិការក្រសួងសុខាភិបាលសូមគោរពអញ្ជើញ
His Excellency Pablo Kang, Ambassador of Australia to Kingdom of Cambodia, to acquire the bouquet from Dr. Phan Sandeth. ជាកិច្ចបន្តនេះខ្ញុំសូមគោរពអញ្ជើញឯកឧត្តមតនតបណ្ឌិតលឿនបូរ៉ារតផ្ដល់ជូននៅវត្ថុអនុស្សាវរីយ៍និងសូមគោរពអញ្ជើញសាស្ត្រាចារ្យឯកទេសហំជាកិច្ចបន្តនេះខ្ញុំសូមគោរពអញ្ជើញឯកឧត្តមតនតបណ្ឌិតលឿនបូរ៉ារតផ្ដល់ជូននៅវត្ថុអនុស្សាវរីយ៍និងសូមគោរពអញ្ជើញសាស្ត្រាចារ្យហំសមេតឡើងលើវេទិកាដើម្បីទទួលវត្ថុអនុស្សាវរីយ៍
បន្តទៀតនេះខ្ញុំបាទសូមគោរពអញ្ជើញតនតបណ្ឌិតឯកទេសភេងនិស្សិតឡើងមកកាន់វេទិកាដើម្បីទទួលវត្ថុអនុស្សាវរីយ៍
ជាកិច្ចបន្តនេះខ្ញុំសូមគោរពអញ្ជើញលោកតនតបណ្ឌិតឯកទេសផានសាន់ដេឡើងមកលើវេទិកាដើម្បីទទួលផ្លាក សម្រាប់ខ្ញុំឯកឧត្តមតនតបណ្ឌិតលឿនបូរ៉ារតសូមគោរពឯកឧត្តម
សេចក្តីបន្តខ្ញុំបាទសូមគោរពអញ្ជើញសាស្ត្រាចារ្យហងសមេតផ្ដល់ជូននៅមេដាយដល់តនតបណ្ឌិតឯកទេសផាន់សាន់ដេសូមគោរពអញ្ជើញ
បន្តទៀតនេះនាងខ្ញុំសូមគោរពអញ្ជើញលោកតតបណ្ឌិតឯកទេសផាងសាន់ដេផ្ដល់ជូននៅវត្ថុអនុស្សាវរីយ៍ដល់សាស្ត្រាចារ្យសូសាភីសូមគោរពអញ្ជើញសាស្ត្រាចារ្យសូសាភីឡើងមកលើវេទិកាសប្តាហ៍សាស្ត្រាចារ្យសូសាភីគឺជា board advisor នៃសមាគមចា៎
បន្តទៅទៀតនេះសូមគោរពអញ្ជើញ Board Advisor លោកជំទាវតន្តបណ្ឌិតអេងនីគង់ឡើងមកលើវេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ
ជាកិច្ចបន្តសូមគោរពអញ្ជើញ Board Advisor លោកស្រីឈុំចន្ទាសុភាឡើងមកលើវេទិកាដើម្បីទទួលវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ Please welcome a live background. ជាកិច្ចបន្តទៀតនេះសូមគោរពអញ្ជើញ Live Member តន្តបណ្ឌិតទឹកសវត្ថិរោឡើងមកលើវេទិកាដើម្បីទទួលវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ
បន្តទៀតនេះខ្ញុំបាទសូមគោរពអញ្ជើញសាស្ត្រាចារ្យគៀមបូនដែលមានតួនាទីជា Live Member ឡើងមកកាន់វេទិកាដើម្បីទទួលវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ ជាកិច្ចបន្តទៀតនេះសូមគោរពអញ្ជើញសាស្ត្រាចារ្យគៀតលីសេកដែលជា Live Member នៃសមាគម ជាកិច្ចបន្តខ្ញុំបាទសូមគោរពអញ្ជើញឯកឧត្តមតន្តបណ្ឌិតអឿនបូរ៉ារ៉តបន្តជូននៅវត្ថុអនុស្សាវរីយ៍ទៅកាន់ម្ចាស់ឧបត្ថម្ភកម្មវិធីសូមគោរពអញ្ជើញ Diamond Sponsor MIS Import និង Export ឡើងមកកាន់វេទិកាដើម្បីទទួលយកនៅវត្ថុអនុស្សាវរីយ៍បាទសូមគោរពអញ្ជើញ សូមគោរពអញ្ជើញ B&B Dental Implant Supply ដើម្បីបន្តជូននៅវត្ថុអនុស្សាវរីយ៍ បាទបន្តមកទៀតសូមអញ្ជើញ Gold Sponsor ក្រុមហ៊ុន DSKIS Cambodia LTD គុណសូមអញ្ជើញឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍ សេចក្តីបន្ទាប់ខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Excellent and Power Supply ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញបន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor របស់យើងគឺ 3DS Quality and Power Supply ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍ បន្តទៅទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor ជាលេខា Institute of Surgical Pathology ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍បន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Metro Nicam ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញបន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Neo Bioden Dental Supply ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍ហើយបងជាថ្មីម្ដងទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Global Dental Supply ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍បន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Phan ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍បន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ Go Sponsor Sandeth Distribution Cambodia Co Ltd ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍ជាចុងក្រោយសូមគោរពអញ្ជើញ Go Sponsor របស់យើងគឺ Mega Life Science Pty Limited Go Phan ឡើងមកកាន់វេទិកាដើម្បីទទួលនៅវត្ថុអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ ไปទទួលនៅវត្ថុអនុស្សាវរីយ៍ ជាបន្តមកទៀតខ្ញុំបាទសូមគោរពអញ្ជើញ
Please welcome. Next, I would like to welcome Dr. Please to come on stage to acquire the award from His Excellency Pablo. Next, I would like to invite Dr. Oeurn to come on stage to acquire the award from His Excellency Pablo. បន្តទៀតនេះជាកម្មវិធីថតរូបជាអនុស្សាវរីយ៍នេះខ្ញុំសូមគោរពអញ្ជើញអាយដាមតនតាបណ្ឌិតលឿនបូរ៉ារ៉តអាយដាមអគ្គរដ្ឋទូតប្រទេសអូស្ត្រាលីប៉ាប្លូកាងសាស្ត្រាចារ្យហុងសមេតនិងតនតាបណ្ឌិតឯកទេសខាងសាន់ដេតហើយចេញមកលើវេទិកាដើម្បីថតរូបជាអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ
One, two, and three.
បាទសូមសិក្ខាកាមទាំងអស់មានការក្រោកឈរឡើងដើម្បីដើម្បីអញ្ជើញដើម្បីជូនដំណើរអគ្គរដ្ឋទូតជូនទៅវិញចាសូមសម្រួលអរិយាបថជាវិកបន្តអឺបរារតសាស្ត្រាចារ្យហុងសមេតនិងសូមគោរពអញ្ជើញ advisor រួមមានសាស្ត្រាចារ្យសូសាភីលោកជំទាវតនតបណ្ឌិតអេងលីកុងលោកស្រីឈុនចន្ទដាសុភីអញ្ជើញមកឡើងកាន់វេទិកាដើម្បីថតរូបជាអនុស្សាវរីយ៍សូមគោរពអញ្ជើញ Please welcome Dr. John Avier, Dr. Barbara Woodhouse, Dr. Omar Barak, Dr. Please.
One, two, and three.
lọt mũi á.
Bạn xong bóng hấn xong người ta sẽ đổ em nhau vào trong ta sẽ bên bật tận kiến so học cùng.
Ladies and gentlemen, it's now time for morning break. Please return.
So respect.
Cái sầm rã sân cái sầm rã đá chắc chắn con
Bạn xong chơi LOC là nó làm một căn bên đại ca làm bấy thọ rụt chung cái gì bạn xong chơi LOC là nó làm một căn bên đại ca làm bấy thọ rụt chung chuyện được sao đi
Cái anh này phải đập chứ cơ. Không qua.
Bên này fly tích còn tay.
ហើយនេះក្រុមហ៊ុន Metro នេះខាងចាស់នេះកោរបស់គាត់នេះទៅពីបងតកាចាំទៅសាលីស៊ីនឹងឡាយសាលីស៊ីដែលគេยังគាត់មកតាំងពីពណ៌នេះគឺដាក់ទៅបានច្រើនវគ្គកាត់ច្រើនខ្ញុំដឹងសិនទៅទេគាត់ថាទៅហើយបាទចាំអរគុណច្រើនបាទខ្ញុំប្រើដែរខ្ញុំប្រើសូមមកវគ្គកាត់តអានេះខលល្អដែរបើខ្ញុំប្រើសេរីនេះអាចប្រើបានខែបាច់ទិញពី Zoom ទេ they last forever. Yeah, last forever. What is new improved by the option you saw on? Vì còn là những cái đặt còn là những cái chuyện quen và còn rồi anh lấy đi chơi giọt xử lý tiền cái kia có nhìn thấy nhiều không nhìn thấy nhiều là bộ đắp là bộ đắp là picture rồi còn one in plan là muối one like muối đó like đó nhưng mà ở nào in the world và đặc biệt one this why quay quay cái đó làm cái người bên đây chúng ta có một cái học qua ở
please return to the conference hall as the event will start momentarily. Thank you.
Mana mong
Participant, please return to the conference hall as the event will start momentarily. Thank you.
buôn đổi form buôn ở đây rồi phải mang nó mà lại phải lo ngon một tô
nhóm mình đi chào người ta em cho ta hai ngón được rồi mình ngon đi nè cho ta
Participant, please return to the conference hall as the event will start in a few minutes.
Nước prực nâng độc thực cho anh áp quạt nâng quạt sài nơi vật thiên bọt mùi chu là dịch hạ cam ở khía đại miền chấm nón chương tha management of jaw fracture from past to present và chắc sông ở bao giờ tôi quạt khang khang nón biết à khang please make a statement.
Privilege of being asked to speak today. I am aware that my Australian accent is difficult for my ear to understand. So I will try and speak slowly. If I'm speaking too quickly, please tell me. It is a great honour and a pleasure to be asked to speak, particularly about this topic of the evolution of management of facial fractures, because I am aware that the very first documented facial fractures in history were actually in this country, and the carvings on the wall at Angkor Wat of this my laser pointer doesn't work up here, so have to look at the side screen. This poor man is being speared in the face, and this poor man is trying to pull an arrow out of his face on the walls of Angkor Wat. So I'm aware that of all the countries to speak about the management of facial fractures from past to present, this is the most appropriate country. But of course I'm not a command man, I'm an Australian man, so the talk will obviously have a relevance to management of facial trauma in Australia, where the etiology is quite different. In Australia, our emblem is the kangaroo, and the kangaroo, like humans,
punches out at the face of someone he doesn't like. And in Australia we have, as well as your formal football we call soccer, we have rugby football, and by far the biggest game in Australia is the game between my state, the red team, and the blue team, in fractures. I first came to Australia, from Australia to Cambodia in 2004. I met a very young version of Seng and Prof. Sandeth and Sandeth in the days he couldn't afford a haircut. So over the next few years, lots of things have happened. After 6 years, we finally had a meeting to discuss formal postgraduate training. After 15 years, I was a bit ashamed to know my hair's gone white, Prof. Sandeth stayed black. Okay, the traffic in this country is quite bad. As you know, many people in motorbikes fall off their motorbikes. It's a great source of the fractures for you people. I'm amazed how many people can fit on a moto, 5 people, only the father gets to wear a helmet. And this man has taken his helmet off and put it down here just so he can smoke his cigarette.
Interpersonal violence, alcohol field has made up for the decrease in the injuries from motor vehicles. And of course, seat belts and airbags only work so far. Many countries don't have them. Tuk-tuks fall over and people come out of tuk-tuks, and no number of seat belts or airbags will save the passengers on this bus when it's driven underneath the bridge. And I always like reminding people, even though poor health tends to gravitate towards the poorer end of the community, it doesn't make any of us absolutely immune from bad accidents. And the best example would be Princess Diana. I'm aware that most people in this room are probably too young to remember Princess Diana. When she died, not wearing a seatbelt, driven by a drunken driver in a Paris tunnel, even all her fame and money didn't protect her from fatal injuries. And also, seatbelts and airbags don't protect pedestrians, or even people in the car in the top photograph there. And when a car hits a pedestrian, it usually hits them at thigh level, fractures their femur, throws them up in the air, and they come down face first on the bonnet or on the road. And again, seatbelts and airbags aren't much protection. I mentioned interpersonal violence, which is common to the sporting field. A lot of my photographs will relate to sport. Sometimes the trauma is integral to the sport, as in the boxing, the wrestling, and the combat sports. But often it's outside the sports. And one of our biggest rivals in sport is New Zealand, the country with a similar heritage to Australia. They wear black and white, and they're very good at finding very innovative ways to rearrange the faces of their opponents with their boots or their knees. But a lot of other sports also produce facial trauma. When the face is moving quickly and hits something solid, the face usually comes off second best, particularly if it's a solid wall or a diving board or something like that. And this is a particularly good example of a patient of mine, but I saw on the internet this man playing baseball was running, looking up in the air, tripped over and managed to impale himself on a spike. And they had to cut the fence to get his face off that spike. So there's no limit to what facial trauma can do to a patient. I've been very fortunate the last couple of decades, so I've been part of the panel for the professional rugby sports in Australia. We don't get bad fractures, we get plenty of lacerations, and I've even had to do that to my family members. I've got one son who plays a lot of rugby, and whenever he gets a cut in his face, no one else wants to sew him up. No sooner to get out of this one, you got another one. My other son also likes putting his face in strange places. He was in the riots in America. But fortunately, I have a very genteel daughter who doesn't do those bad things, and for many years worked at the same hospital as me, and it was fun to work with her. One such patient at a children's hospital, this poor boy, kicked by a horse, and I'll show you what we did with him. Okay, I'm supposed to speak about the evolution of trauma over the years. Prior to the turn of the last century, most of the combat in wars and conflicts was swords and spears and wrestling. It wasn't until the mass manufacture of weapons about the turn of the century and the First World War, which had trench warfare, that people stopped being killed and were only injured in a lot of it. Many people were killed, of course, but the trenches where people put their head up to fire their rifle meant that often a projectile with a shrapnel or a bullet would hit their head. It wouldn't kill the person because they had the rest of their body hadn't been affected and affected their heart or circulation, cut off a limb. So the face was often a bit exposed. Look at photographs of old war injuries, and you'll see that about 2/3 of them are wearing these barrel bandages around their heads. And that was a very effective and simple way on the battlefield to immobilise and temporarily treat a facial fracture, and often it became definitive treatment. So much so that look at people who survived those global conflicts. They're healthy and they're alive. They've often got sort of quite gross facial deformities, but that was the origin of the thinking that we could treat facial fractures just by mobilising them. Actually much easier to get a basic healing than it is, say, for a limb injury. And the management of facial fractures didn't change much for 50 or 60 years. One of the pivotal moments was a very famous cricket test between our enemies England in 1977, and the English bowler bowled a very fast ball. With the eye of faith, you can see the contour defect in the batsman's mandible, right mandible, and he was widely praised for his courage going out the next day to bat with a barrel bandage around his head, little realising that if he had suffered swelling, elevation of the tongue, or hemorrhage, he wouldn't have been able to take that off in a hurry. Actually, now is recognised as a bad form to manage facial fractures. We still get patients coming to us, not terribly often, but from time to time. And this young boy, if he started to get great pain or swelling or problems with airway, would find it hard to get that bandage off in a hurry. So as an aside, if you do have to transfer a patient with a mandibular fracture particularly, the soft cervical collar or even a rolled up newspaper provides better support. A bit more on the etiology of fractures. Bicycling is very common in our country. I can't be too sanctimonious because I'm a keen cyclist, and that causes a fracture. Less so with motos and motorcycles because they usually wear a helmet, but the moto riders in our country are very, very organised. They know they're going to fall off their bike sooner or later and fracture their facial skeleton. So most of them go to the foresight of having the facial skeletal anatomy tattooed on their shoulders. So if the surgeon gets lost during the operation, he can take the drapes off and refresh his knowledge of the anatomy by looking at the tattoo. I always hoped that my patients with their tattoos would look like this girl, but unfortunately most of them look like this bloke. And his tattoo was almost an invitation, hard to kill, or let's give it a go, it can't be that hard, so he survived. People who watched the funeral of Queen Elizabeth know that when the soldier on parade in England collapses, hits his chin on the ground, fractures his mandible, he has to lie there till the Queen or the King gets tired and goes home. At least in Australia, if you fall over and break your jaw, you get some medical attention straight away. And sometimes fractures just happen from being in the wrong place at the wrong time. This poor Mahout obviously upset the Damrai somehow. The Damrais turned around and given him a kick. And this is just the very first patient I saw on my very first weekend on call. An engineering student who was learning how to use explosive to develop a railway line, standing too close and hit him in the face. He was hit in the face with a piece of flying metal. And this just demonstrates that sometimes the complexity that fractures can present, with the many different tissue types and the organs and impression special sense like taste and smell and swallowing that are affected by such an injury. If you're treating facial fractures a lot, aware that you will have patients who have a threat to their airway. You need to be able to do emergency tracheostomy in a hurry, and this one had to be secured by a band-aid suture to the skin in such a hurry. One of the great developments over the years in management has been CAT scanning. It didn't exist when I first started training. It was very, very expensive, now readily available. And these two-dimensional slices show you things you would never pick up on a plain film, such as the very thin fracture of the orbital floor and the poor inferior rectus being caught there, giving you what's called a white eye injury. When he tries to look up, his eye doesn't move, tries to look down, his globe is fixed. The next big advantage was the 3D CT scans. Some people think they're a bit of a toy, but I think they're fantastic for me, and they're even better for the patient who understands their pathology. In this case, a condyle fracture with a small fragment pulled by the pterygoids inferiorly and medially. People who manage fractures, of course, know the basic principles: reduction, fixation, and mobilisation. That hasn't changed. Again, I did some of my early training in Britain as a hangover from those soldiers injured in the war. A British Army surgeon devised a very unique way of immobilising jaws by taking off the buttons, off the thigh buttons off his trousers, wiring them onto the teeth, and then running wires or elastics between the arches. Very effective way, perhaps not terribly comfortable for the patient, but achieved the idea. Arch bars have progressed a lot. I quite like these striker ones. They sit up away from the bulbous part of the tooth, and these screws can be just pushed in. We haven't got to drill the hole. They're self-drilling into the soft bone between tooth roots. Obviously, you have to know your dental anatomy to know where the tooth roots are. Very, very good way, and not too many sharp bits. Because if you really have time to make custom arch bars that are either bent from half round, orthodontic wire, or a cast, and they sit very comfortably on the teeth and allow elastics to be used to correct the occlusion. I'll run briefly through the evolution of internal fixation. Plating became commonplace about the time I was finishing my training in the mid-80s. We started off using the, sorry about that, is that okay? Can you hear me? Yeah. We started off using the very thick compression plates like orthopaedic surgeons use. They have little oval holes for the screws. As you tighten the screw, it brings the edges together. You have to use bicortical screws so that it engages the mandible properly, but it worked very well. But they're very bulky, patients could feel them, they had to be removed. And it wasn't long before we moved to mini plates, and they're fantastic. It's the next big, probably the greatest step since I've been training. In this case, we use for little tiny condyle fractures. Sometimes I put on 2, and if the fragment is very, very small, you know, put 1 screw, 1 end. Actually, sometimes even use 3 little plates to stabilise the condyle. The plates can be modified for use in things like orbital floors, an orbital floor fracture like that first patient I showed you where the muscle below the eye was trapped. A variety of different shaped angle of the mandible, the most common site of a fracture. My preferred method is a 6-hole plate, 3 screws each side. A 4-hole plate sometimes will just still flex a little bit. I find a 6-hole plate contoured to the external leg ridge gives very, very effective stability. And the rare occasions you have an unstable fracture like this one here that displaces easily, I place a 2nd plate with the screws with little stagnancy angle to the mandible and the parasymphysis on the other side. Again, my preferred method is to use wires to reduce the fracture, 1 around the teeth, a figure of 8 at the lower border, away from the mental nerve of course, and just a single plate to stabilise it. My trainees always argue with me, they say you should put 2 plates in, gives you better reduction. I say a plate doesn't reduce, a plate fixes. It's the wires that bring the edges together. And as you can see, I'm very keen on lower border wires. I will not need much encouragement to make an incision underneath the mandible, keeping the wires away from the teeth, of course. As a general rule, I've found that if you don't get this exactly right, it can be sore for weeks on the occasional patient. It does develop a sort of a pain syndrome there almost. I feel very happy putting a wire on, getting a very, very good reduction, and then placing the plate. And if the wire and the plate are touching, you want to avoid galvanic currents, you can take the wire out once you've got your fixation plate on. But having grown up in the pre-plating days, I'm very, very comfortable with wires. The face, of course, has lots of creases and little places you can hide incisions. The trainees who are here, where's Peng and Huck and Vishnu, are all here somewhere. You might want to write this down. I expect you to know this. It's one of the most important aspects of managing facial trauma, is to know where you can hide your incisions. There's quite a few places you can hide them and heal very well with minimal problems for the patient. Just showing a submandibular approach, incising down below the angle of the mandible on submandibular skin crease. Next big advantage, since I started training, is the little disposable nerve stimulators. You can find branches of the facial nerve, identify them and preserve them. The plate provides greater mobilisation and fixation long term. It's a terrible social inconvenience for work and every other aspect of living. But occasionally you do have to resort to it. Perhaps the most common one would be gross comminution of the mandible. This girl, we think was hit by a car, she couldn't remember. Indulgence in alcohol. She had a fractured femur, always a giveaway from a pedestrian being hit by a car, and just a small laceration in her chin point. With the CAT scan, you can see the mandible in multiple pieces. So many pieces we used, several plates and screws here, and the force on the chin point not only fractured the mandible and the dental alveolar fracture in the maxilla, it fractured the condyle and even the zygomatic arch, such was the force with which it hit the ground. So in that case, there's too many fragments to displate them. You can see that you've got IMF wires on there as well for stability. The other relic from the past, from my training days, was mid-face fractures. Before plates were invented, you could open up and fix it. You had to use these box frames and halo frames. Again, very inconvenient for the patient. And this is just one I did with Sandeth a few years ago. This poor fellow suffered facial trauma a long way from Phnom Penh. Arrived in Phnom Penh 2 weeks post-injury. All he could do was swallow bits of his saliva and sips of water. So he was very, very dehydrated, very, very cachectic and malnourished when he arrived. But he filled him up with fluid and blood before he could contemplate surgery. I think he's broken just about every possible bone in his face, probably in a few different places. Start off with the mandible, get the big bits right. Start off around the orbits, get those bits right, and gradually bring the sandwich together. And we used a large number of plates and screws that day. This is my personal record. This fellow in Australia tried to kill himself by driving his car into a brick wall. Unfortunately, he didn't kill himself, but he's got 20 plates and 101 screws. You want to count them carefully. This is a side for patients like that who've got terrible fractures. It's often hard to put a nasal tube down, and you don't want to put an oral tube down if you can't put their teeth together. Make a little incision down here to pass the anaesthetic tube to the submental region. It's a great little trick to keep up your sleeve. A simple dissection here. John Tassie, you would have seen this, would you, in your career? No, it's a terrific way of getting a tube in. The dissection up here, the scar can be hidden in the submental skin crease. You don't try and pass the real tube, you pass a little test one. You pass the little pilot cuff first of all, because once you've got the tube through, you can't get the cuff through. And you make the definitive tube actually disconnected and it stays out of the way. In the operation, you just reverse it. Plates are great for thin mandibles. I'm sure you see a trickle of elderly people who've lost their teeth and their mandibles have become grossly atrophic. It's great for non-united fractures here, a very poorly fixed fracture with a single wire, non-union across the ramus here. So we open it up, we've cleaned out the fibrous tissue, we've got bone graft in there, and they get a compression plate just to put as much reduction as we can of the bone graft. In a similar case, this fellow, a guardsman, he fell over and fractured his mandible from a fall in his chin, lost a lot of bone here, got a non-union. These plates have all been taken out again, a bone graft put in, anatomical arch bars made so we could get the occlusion exactly wanted, and a compression plate. For occasional cases of tissue loss or infected fractures, we have to resort to external fixation. This fellow fell over playing drunken football on Christmas Day. He presented occasionally mid-February, that's about 6 weeks. This fracture was a simple non-union on the left side, infected on the right side. And he had a big beard on when we first saw him, there was pus dripping out of the beard. He said, here's a razor, come back with the beard shaggy. Yeah, there's fish. He said, no point in trying to put metal work inside something like that. And you clean it out, you put the external fixation on till the infection under control, then you can manage the fracture. He thought this was fantastic because no one would pick a fight with him in the hotel while he had this on his face. And he said, oh, that better, that's my try with a bit of wood. For frontal sinus fractures, the plates can be provided with bone substitutes. You're probably all familiar with people who've come off bikes or cars and hit something solid. Nature's crumples are called because it fractures into many pieces. Often it's hard to get every last little piece in, so you can use bone cement here, place via the bicoronal flap. Patients often don't like the thought of a bicoronal flap. My little way of selling children, difficult concept, but actually quite simple to treat. They rarely displace much, and even though these developing tooth buds inside the mandible have to be considered, actually provide extra stability. I found often just placing wires around these teeth. Till they become loose, the deciduous teeth are actually a great anchor point, and they have a lot of force put on them and reduce the fracture quite nicely. The arch shape in children doesn't vary much, and when I do use an anatomical arch bar, as I call it, I tend to not throw it away, I keep it, sterilise it, and it's remarkable how often you can just bend a little bit to suit the next patient and provide a good fixation. You do have to open it up. I try and place my holes right in the cortex so we avoid these massive tooth buds in the mandible. And cases like you might see here that present late, can't get a CAT scan, just got to open up and get a plate on where you can. Briefly, resorbable fixation had a brief period of popularity in Australia when we still use it for children, where we don't want to put metal inside a growing bone. The disadvantage is you can't show a patient how clever you are with the x-ray afterwards because the resorbable material doesn't show up. Fixing a fracture here, and even for the problematic or the very common presentation of an angle fracture at the back, you can just see the plates and screws there. See the holes for them, but you can't just see the plate. Where we do still find them useful, they've sort of lost popularity for conventional adult fractures, but for children like this boy I showed him, got kicked by a horse, he's fractured his skull, it's fractured his lateral part of his orbit, fractured his zygoma, which of course is then pressing against the anterior part of the coronoid, meaning he couldn't open his mouth, it made for a problematic intubation. There's the plate, you can just see the screws there, you can just see the outline of the plate there, the eye of faith. There he is afterwards, looking pretty good. A little bit of enophthalmos in his eye there. And this is how it's put in. The fracture's reduced, the plate's on there, it's clear, it's hard to see. And the little screws are placed with a little adapter that heats them up, they soften a little bit. So you push them in almost like a rivet rather than screw them in. Push in, again provide great fixation. Sonic Weld is the brand, free plug for Sonic Weld. That's the same patient. My faded figure 8 border, figure 8 wire at lower border, my tire wire around the teeth, and the Sonic Weld plate, great fixation. Finally, just to finish off, a particularly unusual case at the other end of the extreme from the gross atrophy of the mandible, thanks, is this neonate girl had a phone call from the obstetrician who said, I was putting the forceps around the head and I felt the crack, I fractured this baby's mandible. I said, well, a lot of forceps deliveries, but always told that it was a risk factor, I've never actually seen it. When you see the model of the forceps being applied, and sure enough, there's this unhappy baby here, nasogastric, because he wouldn't feed, and you can see the mandibular asymmetry there. Now, in an obstetric hospital, it's very hard to get good x-rays, but with plain view, you can see quite clear mandibular asymmetry there. The baby was one of a twin born to a 40-year-old large Polynesian woman having finally conceived after multiple IVF attempts. He had been a fairly dramatic delivery. One twin was thriving, one wasn't. So after a few days of scratching our heads and 2 independent paediatricians and my daughter telling me the baby wasn't thriving, we thought, take them off and get a CAT scan. You don't often see a CAT scan of a neonate, but there it is there. And I think what's happening is the symphysis is open and you've got a little separation of the lower border, and it's probably the pressure of the forceps that have done that. Fortunately, we didn't have to treat it. Having the x-ray done seemed to be therapeutic. The baby started feeding, started thriving. If you did have to treat it, I make a little sort of crooked splint to wire around there that would be mobilising. Fortunately, the baby wasn't terribly distressed, just wouldn't feed. Anyway, having had the x-ray done at another hospital, transferred back, started to feed, was discharged, still looking a bit asymmetric, but patient complaining of asymmetry. We pleaded with the mother to come back and she never turned up. We rang her up and said, how's the baby doing? Very well. If you get a sense of the photograph. So sitting in the church pew one day, someone snapped this photograph, and I think the asymmetry is actually getting better. So this patient may or may not request correction of asymmetry in 15 years' time. A very quick word about prevention. It's, as I mentioned, I'm involved with professional sporting teams. When they have fractured mandibles, we place extra pads around their headgear. A bit different from cheekbones. This is the most historical cheekbone. Protected was Hannibal Lecter in Silence of the Lambs. Players often copy it. When players fracture their orbits or their zygomas, they're very keen to get back playing in a week or two, not aware that their orbital floor is still weak. A variety of things have been tried, including putting foam pads on conventional headgear. I was the model here. I got them to take a plaster model of my head, make a positive, and make something like this. It's PVC sandwiched between the foam, which provides quite good protection. I've had some high-profile professional players wear it. This one's actually made of rubber, like sandshoe rubber, and the Australian rugby captain, who's now one of our politicians, had to wear one for a while when he fractured his zygomatic. For the benefit of the people in this room, I gather play what we call football, what we call soccer. Players often run the goalposts, fracture their cheekbones. This is one of our town star players. So in conclusion, I thank you again for the invitation to speak. It's fantastic. I'm sort of applauding your efforts at reducing motor vehicle trauma. The ads around the town for people coming off bikes wearing helmets is commendable. It's one of our proudest moments. I'm sure Barbara would agree with me here. Barbara, attending the graduation ceremonies of our trainees. Fantastic. Thank you again for your hospitality, the meals you provide, ferrying us around town, your friendship. Please, anyone coming to Australia, come and see us. We've had Sandeth come to Australia, we've had Sandeth come to Australia and enjoy our climate and our scenery. Sandeth was smart enough to like sunning himself in my garden. Sandeth took to the waves and didn't catch waves very well. He's got other skills. So thank you again for your attention. I'm happy to answer any questions.
Thank you, Dr. John, for your excellent sharing. សូមជំរាបដល់លោកគ្រូអ្នកគ្រូថាគាត់មិនអាចចាំ pointer គាត់មក screen ធំបានទេដោយសារវាកង់គ្នាអញ្ចឹងហើយបានគាត់បញ្ចាំងទៅ screen ទូលបាទអញ្ចឹងធ្វើឲ្យបងប្អូនពិបាកតាមគាត់អញ្ចឹងបងប្អូនប្រហែលជាមានសំណួរច្រើនបាទប៉ុន្តែមុននឹងឲ្យវេទិកាទៅបងប្អូនសូមសួរគាត់មួយសំណួរសិនបាទហើយសួរជាមួយបងប្អូនដោយសារបងប្អូនទីច្រើនជា general dentist អញ្ចឹងខ្ញុំសួរគាត់ថាតើគាត់មានយុទ្ធសាស្ត្រអីជាអនុសាសន៍សម្រាប់បងប្អូននៅពេលដែលបងប្អូនមានអ្នកជំងឺ fracture ទៅដល់កន្លែងទីបងប្អូន So my question to Dr. John is what is your recommendation to our general dentist here when they got the fracture patient? Yes, they are not maxillofacial surgeons, so they have to do the primary intervention. So what is your recommendation for primary intervention essentially?
Well, it's a great question. How long have I got to access to specialist treatment is limited. I think as a general concept, the advice would be to be aware of your limitations and don't try treatment that you feel is going to be is unlikely to be beneficial to the patient. As we know, a lot of fractures will heal if they're just immobilised. So if it's an undisplaced fracture or minimally displaced fracture that can be reduced just by application of eyelets and arch bars, it's fine. Don't do it till the patient's fasted. Put a big suture through the tongue so you can pull it forward if they do become obstructed and work them away together. If you do feel like attempting plating, go and do a few courses, come and work at the hospitals with our specialists here. We're always looking for keen people to join the training program. Just try and garner as much knowledge as you can, and at the same time advise the patient that it still may need specialist referral, which is fairly straightforward if you're non-Penh, less so if you're in Siem Reap or in the eastern areas. Very, very broad answer to your question, so please.
Thank Dr. John. ឥឡូវលោកអ្នកគ្រូអាចមានសំណួរអាចសួរគាត់បានពេលនេះអាចសម្របសំណួរមកគុណទូសិក្ខាកាមនេះខ្ញុំរូបថតមួយស្រាប់គ្រូអាចឈរដើម្បីឲ្យបងប្អូនតាមស្គាល់គ្រូបាទខ្ញុំឃើញក្នុងរូបថតមួយក្នុង fracture plancher de l'orbitre គាត់ដាក់ plaque anglia perforée តើគាត់យកចេញឬក៏អត់ពីព្រោះពេលហ្នឹងដែល muscle droit inférieur អាចចូលក្នុងនឹងហើយធ្វើឲ្យមកផ្នែកខាងសួរគាត់ទីមួយថាតើខ្ញុំនិយាយនឹងតើខុសព្រោះខ្ញុំអាចមើលចំណងហើយបើសិនជាត្រូវតើគាត់ដកចេញឬក៏អត់ពីព្រោះធម្មតាគេដាក់ plaque Dr. John, he asked about orbital fracture. When we put the titanium mesh, whether we take it out or keep for a long time.
Well, I always leave it diligent in your dissection back and make sure that you've freed up the muscle completely from that little trap in the orbital floor. Sometimes you even think you've treated it just by the release, particularly with children, that white eye. Often it's only a little bit of the fibrous capsular muscle that seems to be caught in the trapdoor. And you release it, you give it a good tug with a couple of pairs of tissue tweezers to make sure the eye is moving freely. And if you've got good adaptation, it's unusual if you don't get good movement back again. Occasionally you'll find the patient still has diplopia in extremes up and down gaze. And if that's a situation, sometimes you'll find a little area where it's not perfectly adapted to the orbital floor. I might take it out then, just to use the opportunity to mobilise the eyeball a bit better and give the best possible result. But 99% of cases I leave it in. Barbara, do you agree? Yeah. Omar?
There is a culture in Europe as opposed to Australia, Britain, America. I've always taken titanium out, so maybe that's where it is.
Not a culture in Australia. The other great thing about orbital fractures is...
speak French.
Sorry?
Vous parlez français.
Oh, un peu. J'avais étudié le français à l'école, mais j'ai oublié beaucoup de français.
Pour la fracture de l'orbite de plancher.
គាត់ឆ្លើយសង្ខេបខ្លីដើម្បីឲ្យយើងងាយយល់បាទអញ្ចឹងថៃធម្មនាមមេសដែលយើង restore orbital fracture ហ្នឹងណាវាអត់មានបញ្ហាអីទេដោយសារអីពេលដែលយើងដាក់ហ្នឹងយើងត្រូវធ្វើតេស្ត mobility របស់ភ្នែកយើងហ្នឹងណាបាទហ្នឹងតើតែសាច់ដុំភ្នែកតើតែអីវាមានធ្វើចលនាបានបានយើងដាក់បើយើងធ្វើតេស្តហើយភ្នែកអត់ដំណើរការក៏យើងអត់ដាក់ដែរបាទអញ្ចឹងគឺមុននឹងដាក់គឺយើងធ្វើតេស្ត បាទទៅតេស្តទៅdiplopia តើគាត់មើលច្បាស់ឬក៏មើលអត់ច្បាស់អញ្ចឹងណា
La fracture de plancher យើង décoller muscle ដើម្បីយើងដាក់បាទយើងដាក់ដៃធម្មតាគេយក paroi de sinus យកមកដាក់ដើម្បីកុំឲ្យមានបញ្ហាហើយយើងឃើញគាត់ដាក់ plaque perforé តែកណា plaque perforé វា muscle ហ្នឹងវាអាចទៅចូលក្នុងperforation ហ្នឹងវាអាច ជាសំណួរទេណា
The titanium plate here have hole. It's not completely covered, so we worry that the muscle might drop in that hole.
Well, that's why this modification was developed with a little elastic sheet over the top to make it smoother. But in fact, again, Barbara and Omar can disagree with me, but I use this in most cases, and I don't think it does get trapped. The muscle itself is too big to go through those little tiny holes. If it does get caught anywhere, it will be at the very edge. It's not adapted properly, I think. But I'm a big fan. I'm not a big fan. I just leave them in unless patients specifically want to have them taken out. You don't get any herniation of the screws because the tissues are quite thick over that. The other great thing with this one is I use the infraorbital approach. I know a lot of people use subconjunctival, but the skin creases in the lower eyelid heal so beautifully that patients are always really impressed with our sewing because the scar becomes invisible unless you look really closely. You go back and take it out, it's never quite as good the second time. Politely disagree with you, sorry, Tony.
If you are fasting, but I think the most important thing is you get a good occlusion, you get fixation, put patient rubber band for 2 weeks.
Trouble is, if you put a 4-hole plate in, it will still flex a bit. And
no, if you adapt well, it's not going to happen.
Well,
I done hunt in this case, German plate.
I don't find any great problem putting a 6-hole plate in. And just occasionally when you open up, you find a little bit of comminution or something around the fracture site. Practice makes perfect, Tony.
Well, I'm simple.
បាទសូមអរគុណសម្រាប់ចង់ឲ្យមានទាំងអស់គ្នាបាទដោយសារគ្រូសរងរោគាត់បារាំងតូនីអង់គ្លេសបាទអញ្ចឹងគាត់ចង់ឲ្យនិយាយគាត់អូស្ត្រាលីបាទអញ្ចឹងគាត់មាននេះការយល់ឃើញខុសគ្នាតិចតួចបាទអញ្ចឹងដុកទ័រទូនេះគាត់ថាដាក់14រុនបានហើយអញ្ចឹងនឹងតាមទឹកដៃគាត់មួយហើយបាទអញ្ចឹងយើងដាក់តាមគ្រូណាក៏បានដែរដោយសារគ្រូធំមួយគ្នាបាទ Thank you Dr. John Avier បាទអញ្ចឹងដោយសារពេលវេលាខ្ញុំសូមលឿនតែម្ដងបាទ Please next speaker welcome Dr. Barbara to the stage បាទអញ្ចឹង Dr. Barbara will say about facial deformity បាទអរគុណបាទ Please Dr. Barbara
and the organising committee for the invitation to address. Good morning, ladies and gentlemen, special guests. I'm going to talk about combined orthodontic and surgical management of facial deformity, so essentially orthodontics plus surgery. And sometimes we do surgery first, but mostly it is orthodontics first for about a year, then surgery, and then finishing orthodontics. Is this supposed to advance? So, I'm going to look at the role of surgery and the role of orthodontics, assessment of the patient, the planning of treatment, of which there have been some big advances lately with digital planning using CT scanning, the timing of treatment, and cover some of the procedures that we use. So, surgery is necessary when there is a skeletal deformity as opposed to just poor tooth position. It's ideally in conjunction with the orthodontics, and the orthodontics will... We are not the primary treaters. The orthodontist is the primary treater, and we simply provide an aid to orthodontics to reduce the treatment time, to make movements which will be impossible without surgery and just using orthodontics, and to provide some anchorage, to provide segmental procedures, although there is a lot of morbidity of blood supply loss when we perform segmental procedures. And sometimes we can simultaneously put in implants to replace missing teeth, but only in the mandible, not in the maxilla, because that will compromise the blood supply. I would like to emphasize that it is always a team approach between the dentist or the prosthodontist and the orthodontist and the surgeon together. There is no role for each person doing their bit and then passing it on. It requires a plan as a group. We can use it to manage post-cleft deformity. Babies who have cleft palates repaired, their maxillas do not grow, and so we then have to surgically advance the maxilla after puberty. And also in the management of obstructive sleep apnea, where patients have jaws that are too protruded and it impacts on their airway at night time, and advancing the jaws will sometimes improve their sleep apnea. So, what are we going to assess? As in all of medicine and dentistry, the first thing we look at is the presenting complaint. Is the patient concerned about function, or are they concerned about aesthetics? Maybe both. A lot of patients say to me, my teeth don't fit together properly, I want to have the surgery. Look at the relationship of the skeleton to decide whether surgery is needed. The relationship of the dental arches, where orthodontics will align the teeth before we do the surgery. A dental assessment is whether their teeth are healthy, have they finished growing, because otherwise we might do the surgery and then they grow in the wrong direction and it undoes any good that we've done. And a psychological assessment, because it's a big operation. So in the skeletal assessment, we're looking at the lateral plane. We divide the face into thirds, from the hairline to the glabella, to under the nose, subnasion, to submentum. And each of those thirds should be equal for vertical harmony. So we've routinely, conventionally in the past, used lateral cephalometrics to do this. It is X-ray shielded, you will see, so we can see the soft tissues. Is this? Wrong way around. That's why. The soft tissues as well as the hard tissue on the X-ray, because we are designing the shape of the soft tissues, not just the hard tissues. And we're looking at forward projection as well, all on this X-ray. And then we look from the front with a frontal X-ray. And we look at symmetry, left is to right. Is there any canting or wrong angle of the smile? Where is the midline of the top jaw and the bottom jaw? And is that coincident with the face? And finally, the facial fits. So the face should be divided into these fits to make it symmetric across from right to left and left to right. Now, all of that can be done with digital planning with a CT. We don't do this in the beginning because the CT has a big radiation dosage. So we will still use conventional planning with those X-rays in the beginning, but when we come to the stage that the patient is ready for surgery, we ensure that they have their surgical archwires placed by the orthodontist and that they are passive, that there is no more tooth movement going to occur. And then we take a CT or a CBCT. The problem with CBCT is what we call gantry width. We need to have from the glabella to submenton on the one film, and sometimes the CBCT is not wide enough to do that, so we have to have CT. We take an impression and make models and then do an optical scan of the model of the arch, or we can do an optical scan of the arches and produce an STL file. And we have to include the palate. Now normally when we scan the teeth, we just look at the arch closely with the orthodontist. And this is what we get. We put the DICOMs from the CT and the STL file of the arches into the software, and we get this here. And you can see the gap between the teeth is equivalent to the putty bite. It's no problem. As long as the condyle is seated, we can rotate the mandible up virtually in the software. And sometimes if we're doing segmental, we'll have two halves of the maxilla, or maybe even the maxilla in 3 pieces, according to what shifts we need to make. I will come back to that later and show you a little more on digital planning. So, we have all these records ready to go, and we look at all the angulation, the arch form, how the arches fit together. We're going to talk to the orthodontist about what we need to do before the surgery to decompensate. So this person, there is nowhere to move the lower jaw because the overbite is very deep and there is no overjet. So here I will work with my orthodontist, and the orthodontist will procline those upper teeth to get rid of the crowding, because proclination makes more space, and then to create an overjet into which I can then advance the mandible. So it is always a team approach. We always decompensate, and we spend that year while the decompensation with the orthodontics is happening to educate the patient about what's going to happen. Essentially, it will get worse before it gets better, because as the orthodontist proclines those teeth, the patient is going to start to lip trap, which is not a good look, and they need to know to expect that for a short period of time before we do the surgery to correct. They also need to know that there will be 3 to 6 months of post-surgical finishing orthodontics. We can only be accurate to within 0.5 to 1 millimetre surgically. The orthodontist works to much lower tolerances and will finish off. We may have a lateral open bite, very common in Class 2 Division 2 malocclusion, once we've advanced the mandible. And that lateral open bite needs to be closed vertically. We need to tell the patient about their recovery time, which is longer if they're having 2 jaws than 1. And we give them lots of literature and even introduce them to other patients who have undergone the surgery. So, they have up to 12 months of pre-surgical orthodontics, between 2 and 4 days of hospitalisation, about 10 days to 3 weeks of recovery before they can go back to work, about 3 months of mid-facial swelling if they've had a maxillary procedure, because the lymphatic drainage of the area is very poor there, and about 3 to 6 months of post-surgical orthodontics, and I will see them for a minimum of 12 months follow-up, longer if I have concerns that they are still growing and I need to monitor that. So on that basis, we should be treating the patient when they have finished growth as late as they will be tolerated by the patient. But of course, if the patient has a problem, they are push us to treat early, and sometimes we need to resist that to get the best result. Less important with Class 2, because they stop growing early. Less important with females, because they stop growing early. But class 3 male, I don't like doing before 20, 25 because they still grow up until that point. Orthodontics can start when we can see that the rate of growth is slowing. The mandible stops growing usually about a year after the height finishes. So my patients record their height. And when their height is stable, we put the braces on. 12 months later, we expect that the mandible will have stopped growing and we do the surgery. Sometimes I cannot do that, and it's necessary to overdo the correction, so when the mandible continues to grow, we still have the right occlusion. Sometimes we will use investigations such as radioisotope scanning, which is an injection into the bloodstream, which then settles out in areas where there is lots of blood supply. Growing joints, growing condyles have lots of blood supply. So we can see here that there is an accumulation of the tracer in the right condyle as opposed to the left. And we know this is an asymmetry case, that that right condyle is still growing. We need to wait until it has stopped, or we need to stop it growing with a different operation, a high condylar shave, before we can do conventional orthodontics and orthognathic surgery, or the continued growth will undo the result and the patient will not be happy. The procedures, these are all the ones I'm going to show you very carefully. So we have this portfolio of operations that we can do to affect various types of movement. Our workhorse in the mandible is the bilateral sagittal split osteotomy, BSSO. And this is how it is performed. The buccal cortex is split from the lingual cortex, usually exposing the nerve, so there is some numbness for a short period of time post-operatively. We can set the body backwards to reduce the prominence in class 3, or we can advance it, as you can see here, with a gap. So this gap is only monocortical. The lingual cortex is still present. And then the buccal cortex will grow in the next 3 months. We have to take great care with rotation, because rotation of the body is not stable. These are lesser popular procedures such as a C or an L, or a vertical subsigmoid that cuts through the sigmoid notch posterior to the nerve. The subapical, where we need to just move the incisor teeth if they are super-erupted in class 2 div 1. We can take a section out here and move the section down. We can also do a split right through the symphysis to narrow the mandibular arch or to widen the mandibular arch to match the maxillary arch. And Dr. John's special operation, that always when I have a patient who needs it, I ask him to help me because he is so good at it, is the body ostectomy, where we actually take out a segment of the mandible and put the anterior mandible back. Or we could put it forwards, I suppose, and graft, but we do that far less often. In the maxilla, the workhorse is the Lefort 1 osteotomy. So that is at the level of the nasal floor. And we can advance, we can move the maxilla forwards, we can push it upwards, we can bring it downwards and graft, we can rotate it, and we can what's called yaw it. So this is a young lady who has insufficient maxillary projection, and she's had a simple advancement, and this is her post-op result. This is a young lady who has what we call vertical maxillary excess. When she smiles, we can see not only the teeth and the papilla, but we can see the roots of every tooth as well, and it's not an attractive appearance. So we have simply impacted her maxilla, and we can see her post-op result. And if there was a problem with angulation or an anterior open bite, we can correct that with the Lefort 1 maxillary osteotomy as well. This is a lady who has vertical maxillary deficiency. She has teeth, but she looks like she has dentures and left them out because she's overclosed. So we have, sorry. Okay. We have downgrafted her maxilla, so now when she smiles, we can actually see some teeth. But it's important in this one that we overdo by about 30% because there will be some resorption of the graft. Where do we get the bone? Well, if they're having a BSSO at the same time, we can take lateral buccal cortex and use that. Or we can use chin, or we can sometimes use iliac crest on the hip as well. And we can rotate with the maxilla to correct a midline shift. So this is the 4-2 level, this is much higher, and this is the 4-3 level, which is very high. This requires the bicoronal flap that Dr. Avia showed you. As well in the maxilla, we can expand with an orthodontic appliance. We can do a partial of 4-1 osteotomy, split the midline, and expand the arch. This is called a SAMI, or surgically assisted maxillary expansion, and we can do segmental procedures to move segments up or down, but with great care because it's more difficult to preserve the blood supply, and we can get loss of blood supply, loss of segments, which is a disaster. We can also operate on the chin, and we can bring the chin point forwards, and we can do 2 layers, like bring the bottom forward, and then underneath that, the bottom a little bit further forward to get a lot of advancement. We can reduce it if it's too far advanced horizontally. We can lengthen the chin, and we need a graft in that situation. We can reduce the height. We can change the midline of the chin. We can change the cant of the chin, and we can do a combination of all of the above as necessary. So this is a young man who's had his orthodontic treatment. He was never offered surgery and came to me saying, I don't like the way my face looks. And he simply had a chin advancement, and that is all, which has given him what he wanted. His teeth are great, but his face was terrible. So now it's much better. So this is where we have a lady who has a very, very short face. She's very short from here to here by comparison with her other facial thirds. So she has had a horizontal reduction and vertical augmentation because the chin is very prominent. So we've made an oblique cut, and as we slide the chin down to increase the height, it also goes back to reduce the prominence. This is a lady who has a pure vertical augmentation, and this is the one where we get a gap, so we need bone. And again, we can take that bone, not from the chin this time, because we're operating on the chin, but we can take it from the lateral mandible, and we can take it from other parts of the body, such as the iliac crest, or the skull, or wherever. Vertical reduction, this young lady had a very long chin, and it was making it difficult for her to even have her lips to get together, and now we have shortened it. And a midline shift, so this young lady has her chin off to the right-hand side, the middle of her chin is underneath the right side of her nose, and post-operatively it is straight, and it was also pointing downwards, and post-operatively it is parallel to her pupils. We always use the pupils as the baseline, because that is what everybody looks at. When you meet someone, you look into their eyes, and your brain takes its reference from the eyes. Everything else has to be parallel to the eyes. We tend now to use plates rather than wires for osteotomies, and that allows patients to function afterwards. With wires, they have to be tied together in maxillomandibular fixation for up to 3 months, which is a long time. I used to use a lot of wires, 1.5, 1.3, or even a 1 mil plate, because we don't need the strength. We now have custom plates and custom cutting guides. So now I'm going to talk about digital planning and custom plates, which are 3D printed from titanium. So this is my plan for the lady I showed you before. And this is the lateral that you've seen. You haven't seen the frontal, so now we have the 2 segments. She's only having her mandible advanced. And what you can see just here is the putty bite that she wears while she's having her CT to hold her jaw in centric relation. And she already has a very, very deep submental fold. Her lip is rolled down by her other teeth because her mandible is protruded. And that's actually made a little bit worse by the putty bite, which is a problem, as you will see, because the software does not deal very well with soft tissue changes. We still have to use our own experience to know what's going to happen to the soft tissues. So this is moving her mandible forward simply to close the overjet. So here is the overjet. We digitally rotate the mandible up until the overbite is achieved, and then we will advance the mandible, and you can see there are now gaps on the lateral cortex where it has been advanced because there is no more overjet. But look what has happened to her aesthetics. I'm not too worried about the lip. When I'm consulting with a patient, I will put my finger or a pencil over that lip so they don't focus on it. Because this is purely the software not having the capability to predict the change. I know that lip's going to come up and recover when it's no longer rolled down by the top teeth, but the computer doesn't seem to understand that. Okay, but you can see that that chin is far too strong for a 16-year-old girl. And so I offer her the alternative of having her chin reduced backwards, and we can do the genioplasty in the software as well. So she has a certain, if you take the putty bard out, she has a vertical lower third deficiency. She's short from here to here compared to other facial thirds. And so by setting the chin point back and sliding it backwards and downwards, we manage both problems. We increase the vertical height and we set the prominence backwards. And apart from the lip still looking terrible, we now have good balance of the nose, the top lip and the chin. And the bottom lip won't look like that after I finish her operation. It will look much better. We also get from the software exactly how far we are going to advance. So I now know I'm advancing her 8 millimeters on the left and 7 millimeters on the right. So intraoperatively, I can measure that, and I know that I have things in exactly the right position. The software will also give us the measurements on the chin, and if there's any canter correction, and any rotation, as well as how far down and how far back. And then we get all the measurements that we know are going to happen. And so I can now go back to put in those measurements and get my surgical plan. Because I want to be able to monitor my patient post-operatively for relapse with lateral cephalometric X-ray, not having to take CT every 2 to 3 weeks. So I can translate this back to old-style planning and use the old-style planning much more conservatively from a radiation dosage point of view to monitor her post-operatively. So this is a patient who had extensive surgery. He became she, and his occlusal problem was that his maxilla was too narrow and too protruded. He had a very prominent chin, which was not suitable for a woman, and he also had very prominent angles of his mandible. So when he became she, we planned to reduce the angles of the mandible, and you can see I've got cutting guides here that fit along the occlusal surface, to move the chin backwards and take a segment out, and to also move the maxilla forwards. And this is my cutting guide. And in my cutting guide, there are 2 lots of holes. There are fixation holes, which hold the guide onto the maxilla before I have cut it. And then we have predictive holes, which I drill before I cut, break, and move. And those predictive holes are where my final plates will be. So all the drilling for the holes is done before I actually do the cut. Then I cut, break down, move forward, and then I put on my plates. And these are my maxillary plates and my mandibular plates, and everything fits, like putting together a jigsaw puzzle. I have a splint, which is also 3D printed, just in case. That's because I'm someone who wears a belt and braces. I always like a plan B. Now, this maxillary plate is very big and very bulky. It extends from here to here. But it doesn't. It is actually 4 L plates, 2 right, 2 left, with 3 little sections holding it together. And when this plate is on, I can break out this section, break out this section, break out this section, and I have now 4 individual plates. So if one becomes infected, I only have to take out 1 plate, not everything from here to here. And that's a very good modification of an existing technique. This is what I receive when I get a plan that I have to sign off on. I have a 3D printed plastic splint. I have a cutting guide for the maxilla. I have my plate for the maxilla with the 3 breakout points, so you can see that will convert it into 1, 2, 3, and 4 L plates. I get a biomodel of how the patient is now and how the patient will be when it's done. And I get the cutting guides also for the angle reduction. I get a cutting guide for the chin, and I get a plate for the chin as well. So all of that comes to me from Germany. But watch this space. KLS are setting up a production plant in Australia and in Asia. So you will be able to access with that within a week to 10 days tops. And if you want to know more, please talk to Jacqueline at the KLS stand. She would love to talk to you about it. I've been working with KLS for a long time, and they're a fantastic company. Great service. Okay, so there are a few other things that I do which are totally independent of the bite. They are purely for aesthetics, well, usually for aesthetics. So I can reduce or enhance the lip. I can reduce the contour or augment it. You saw in Patrick, who became Gwen, there was an angle reduction, so that's purely aesthetic. We can do rhinoplasty, We can do rhinoplasty. We can do submental liposuction if the mandible gets set back. Sometimes a larger patient like me will develop double chin, so we need to do submental liposuction to fix that. We can place implants in the mandible, and we can do osteodistraction. In fact, my favourite way of treating maxillary retrusion in the cleft patient is not full the 4-1 maxilla, because that devascularizes what is already a very scarred maxilla, and we run the risk of avascular necrosis, but of doing it with distraction. And with digital planning, we can totally plan the distraction and the vectors, which always used to be a problem in the past using distractors. So this is a young lady who has she lives in Australia, she's obviously of Asian background, she's actually a dentist now. She was a dental student when she came to me, and one of her problems was she didn't like the fact that her lip was very full and very asymmetric. So this is her post-op view, and I've just done something simple, like taking a wedge out of her lower lip. We can also do lip augmentation. This is the lady you saw before who had a chin procedure. She has no upper lip, and so we can do a multiple VY procedure to create some upper lip without using fillers. This was way before Botox. So, and then this is permanent. It doesn't have to be done every 3 to 6 months. Okay. Contour reduction. This is a lady who stayed a lady, and she had very big angles of her jaw. So as well as maxillary impaction, I reduced the angles, and this is her post-op view. This is also a jaw reduction. Cherubism. This is what cherubism looks like in the adult when it has resolved. Big jaws. We have a very famous actress called Sigrid Thornton who looks like this, and so she's quite old now, but when she was popular, this look was popular. Now she's no longer around, it's not popular anymore, so we do angle reduction. And this is the post-op result. And again, we can digitally plan this so we get symmetry. It's no longer, oh yeah, I think that's about right. Rhinoplasty, contour reduction. This is a lady who had a defect in the lower border, and we just put an implant in. We can 3D print a peak implant that will fit the mandible and just clicks into place. This lady had a rhinoplasty as well as a mandibular advancement. This lady has had submental liposuction, and if you are thinking of getting submental liposuction, make sure you are young, because otherwise you trade a double chin for wrinkles, because the skin doesn't go back when you are older. We can place implant placement. These implants, this man has very few posterior teeth, so his implants are actually placed as a prior procedure to provide anchorage to bring his mandible back. You can see he's very class 3, so his maxilla went forward, mandible back, and the implants provided some of the anchorage for that. And we can osteodistract. This is a young girl who had fibrous dysplasia of the condyle, which was occupying the glenoid fossa and causing what we call a pseudo-ankylosis. She was not ankylosed, but she could not open her mouth because the condyle was too big for the fossa. And so at age 9, I had to remove the condyle and replace it with a costochondral graft from the rib. And then, of course, the rib grafts, sometimes they grow too much, sometimes they grow too little, and very occasionally they grow the right amount. But of course, in her, it didn't grow enough. And so she was already class 2. So she required a 12mm advancement on the unaffected side and a 32mm advancement on the affected side. So what I did was I osteodistracted as much as possible and then allowed it to heal for the bone to regrow, and then did a bilateral sagittal split. The left side split was through the osteodistracted bone. So osteodistraction can be a help in these deformity cases and also, as I said, in clefts. And this is her pre-op. You can see the left side is not grown, so it's the tissues all bunched up, and this is her post-operatively. Post-operative, there's significant facial swelling, and we often take our patients to ICU for the first day. There is always numbness in the lower jaw and the upper jaw, always resolves in the upper jaw. The older the patient is, the more poorly it resolves in the lower jaw. They can have some difficulty swallowing, and they usually have to wear elastics, full-time for 1 week, and then part-time for 5 weeks. Then they go back to the orthodontist. At that stage, they can eat normal things, because until then it's soft diet. We rarely get infections, rarely TMJ pain, and there's about a 10% relapse of advancement, so we overdo. When we plan, we set edge to edge with the incisors rather than a correct overjet, because we know they're going to relapse about 10%, and vertical downgraft relapse is about 30%, so we build that in as well. Thank you very much for your attention. I will be more than happy to take your questions.
Thank you, Dr. Barbara, for your excellent sharing. បាទដោយសារប្រធានបទនេះក្តៅខ្ញុំដឹងថាលោកគ្រូអ្នកគ្រូមានសំណួរច្រើនតែដោយសារពេលវេលាខ្ញុំអនុញ្ញាតមកមួយសំណួរហើយបងប្អូនដែលអត់បានសួរមួយសំណួរនោះបងប្អូនអាចសួរជាមួយ Dr. Barbara ផ្ទាល់បាទអញ្ចឹងឱកាសជាករិតតីបាទ
Thank you for your share your slide this presentation and excellent result. We in here in Cambodia, many people want to change the facial deformity by use another procedure like silicone or filler. They want to change the face, but then here the orthodontic, we need orthodontic. For my question, if they want to do the surgery procedure, how the minimum age they want to you want to do with them? And the second question, if any infection, you said that you have very rare of complication infection. If you have infection with the how long you wait for to do another step surgery.
Okay.
Thank you.
You and I both have the advantage of working in the head and neck, which has the best blood supply in the whole body. And we do things that make our orthopedic colleagues cringe because they don't have that blood supply. And so they worry about avascular necrosis and infection, which we very often don't have to worry about. So your second question, what do I do with infection? It's usually a plate infection associated with the prosthetics. And so it doesn't seem to interfere with ossification of the defect. And so we just wait 6 weeks until the jaw is fused, pieces, because only the infected one has to be removed. I can take almost every plate out under just local anesthesia, except for anterior maxilla, because then I have to tunnel up to orbital floor, and that's not nice under local. So if it's these 2 plates, they have to have GA. Every other plate, local anesthetic. And we rarely get plate infections. I'd probably put in thousands, and I could number the plates I've taken out maybe on my fingers and toes in 35 years. So maybe 20 or less. I've had 1 plate breakage and a few plate infections, a few people who say, I can feel it here when the rain is coming, or my glasses sit on my plate, and we take them out for that reason as well. Your first question was timing. Yeah, class 2, so protruded mandible, female, 15. Younger if you like, because there will be no more growth post-menarche of the mandible. So it's very reliable. Boy, I wait much later. Class 3, prognathism, male. I'd like to wait, and probably he's retired, because they can grow and grow and grow. But about 25 years, there's no more growth. So 25 years old is fine. But if he's pushing me, I will do it 19, 20, 21. But when I bring bottom teeth back, not here, it's here, to allow for more growth. Usually about 1 millimetre per year up to age 25 is my rule of thumb. Is that answer?
We did not see you do the external facet like Elizaro. Some of the surgeons, they do the external facet, they fix, and then they can move every day for 1 millimeter.
Oh, the distractor? There was a couple with the distractors, so I'll just go back if I may. Distractor, Kayla Zurich, and that got me 20 millimeters of advancement. You can just see the neo bone starting to form. Left that on, and when she had bone there, then I do bilateral sagittal split osteotomy through the neo bone to advance the other 12 millimeters. And there's distraction, did I mention that as well? Yeah, and I use distraction with cleft patients to do the maxillary advancement because it's much less likely to result in avascular necrosis. Yes, she turned that every day until she had 20 millimeters, which is the extent of the distractor. This is an intraoral distractor, so there's no scar on the outside. She has a little stick, which she clicks intraorally, turn, click, turn, twice a day. And we also use distraction with maxillary expansion, so partial the 4-1 maxilla, and midline split. Find it. Here we are, there. So this is distractor as well. Hole here, patient has a stick in 90 degree turn. In 90 degree turn. Until we get enough space that the orthodontist says to me, stop. I now have room to align those teeth, and the back teeth are now outside the bottom teeth, so they're in the right position. But again, we need to overdo, because it will relapse when the distractor comes off a little. Thank you.
Same again, Dr. Barbara, và of course, thủ thông là bạn xưa và thủ thông là bạn cách là xong là cô với ca chung là các sản phẩm của bên bạn sao về liền lại rồi.
បាទសូមថ្លែងអំណរគុណដល់ការធ្វើបទបង្ហាញរវាងខ្លឹមសាររបស់លោកតាការបណ្ឌិត
Dr. Hay Fisat for facilitating the scientific session. ជាកិច្ចបន្តសូមគោរពអញ្ជើញដល់តាបណ្ឌិតឯកទេសផានសាន់ដេតប្រធានសមាគមប្រកល់ Certificate of Appreciation ដល់វាគ្មិន ចាសូម I would like to invite Dr. John Avier to come to the stage. Please welcome. Next, I would like to invite Dr. Barbara Woodhouse to come to the stage. Please welcome. Chị kịch bản top so gồm bên chơi là các bạn tên hay bị sắt so chị tự tôi do certificate appreciation. បាទសូមអរគុណសូមសម្រួលអាយ៉ាបង
អាចារ្យបានបណ្ឌិតឯកទេសអង្គសុមេតដែលលោកសាស្ត្រាចារ្យនឹងអញ្ជើញមកបង្ហាញអំពីបទបង្ហាញមានចំណងជើងថា What can go wrong with dental implants tips and hints for preventing implant complications ខ្ញុំជឿថាបងប្អូនបណ្ឌិតយើងស្គាល់លោកគ្រូទាំងអស់គ្នាអញ្ចឹងខ្ញុំប្រហែលជាមិនចាំបាច់រៀបរាប់ច្រើនទេព្រោះដោយសារពេលវេលារបស់យើងគឺខ្លីមែនតើ
board members, local and international speakers ទាំងអស់ខ្ញុំមាន topic មួយដែលចង់ share ទៅនេះដោយសារនៅក្នុង conference ភាគច្រើនគេអត់សូវនិយាយពី complications ប៉ុន្មានទេកាលនោះ face to face group តូចប៉ុន្តែ speakers មាន Dr. John Avier, Dr. Barbara Woodhouse, Dr. Paul Dukes, a few others, Dr. from Singapore, I can't remember the name. The first speakers also lines up very well. Okay, តទៅទៀតខ្ញុំនេះគឺជា objectives មានន័យថាគោលបំណងដែលធ្វើ presentation ថ្ងៃនេះគឺទី1 ជា outline មាន objective introduction និយាយពី prevalence of implant failures what can go wrong with implants យើងចែកចេញជាដំណាក់កាលនៅពេលដាំតើមានអីកើតឡើងអាចមានអីខុសអាចមានអីហេតុការណ៍កើតឡើងនៅពេលក្រោយដាំហ្នឹងយើងចែកជាដំណាក់កាលថាអាទឹមភ្លាមរាប់អាទិត្យតើមានអីកើតឡើងអារាប់ខែមានអីកើតឡើងអារាប់ឆ្នាំមានអីកើតឡើងអញ្ចឹងយើងមានចែកដំណាក់កាលទៅតាម And then what can go wrong with the patients ជួនកាលមិនមកគ្រូពេទ្យយើងនេះកំពុងអ្នកជំងឺគាត់ raise too high expectation គេចង់ស្អាតខ្លាំងឬចង់បានដូចតារា Hollywood ឯទីហោឬក៏មានបញ្ហាជំងឺផ្លូវចិត្តធ្ងន់ធ្ងរអានឹងក៏ជាផលបាក់ដែរហើយទី6យើងនិយាយពី strategies ថាមានយុទ្ធសាស្ត្រអីខ្លះដើម្បីការពារកុំឲ្យ complications នឹងកើតឡើងbegin next slide objectives មានន័យថាគោលបំណងឬទិសដៅនៃការធ្វើការបទបង្ហាញនេះគឺដើម្បី identify មានន័យថាយើងស្វែងរកមើលតើអាមូលហេតុចម្បង common ជាងគេសម្រាប់កើតឡើងនៅពេលតាម implant ហ្នឹងអាចមានអីខ្លះ discuss the possible solutions តើយើងត្រូវដំណោះស្រាយយ៉ាងម៉េចដើម្បីការពារកុំឲ្យវាកើតឡើងច្រើនពេក to share some tips and hints មានន័យថាខ្ញុំមាន
បារាំងថា clay មាន clay មួយចំនួនដែរដែលជួនកាលអត់មានសរសេរនៅក្នុងសភៅឬអីទេមាន clay ចំនួនដល់ពេលយើងធ្វើច្រើនទៅវាមានជួបប្រទះបាទបើមានឯកើតឡើងតើយើងបន្ទោសអ្នកណាប៉ុន្តែការបន្ទោសមិនមែនជារឿងល្អទេព្រោះថាវាអាចបង្កចំនួនអញ្ចឹងយើងគ្រាន់រកថាស្វែងរកមើលតើមកពីស្អីមកពីមូលហេតុអីយើងនឹង discuss នៅពេលបន្ត Next please តាមការសិក្សាស្រាវជ្រាវរយៈពេលប្រហែលជា20ឆ្នាំកន្លងហ្នឹងយើងឃើញថាស្ថិតិនៃfailures និង complication នឹងកើនឡើងជាលំដាប់យើងដឹងថាតើមូលហេតុអីយើងដឹងថាអ្នករៀនអ្នកចង់ចេះដាក់ implant មានច្រើនប៉ុន្តែវគ្គសិក្សាជួនកាលល្អជួនកាលអត់ល្អជួនកាលខ្លីពេកជួនកាលវាអត់មាន basic ឬក៏អត់មានហើយភាគច្រើនគាត់បង្រៀនតែរបៀបដាំដល់របៀបធ្វើថ្មិញអត់បង្រៀនដល់អញ្ចឹងអា failure ច្រើនតែមកពី prototype គេអួតតែរបស់ case ណាដែលគេជោគជ័យគេអត់សូវអួតពីបរាជ័យថ្ងៃនេះខ្ញុំបើកដើមទ្រូងបង្ហាញអាបរាជ័យឲ្យឃើញទាំងអស់ការ study យើងឃើញមានស្ថិតិមានមកពី overload lack of oseo integration មាន lack of augmentation នេះមានភាគរយនៅលើដោយបានបង្ហាញជួនតាក់ទងជាមួយ cositis periimplantitis យើងនឹង discuss អានឹងនៅពេលក្រោយទៀតថាអានឹងមកពីមូលហេតុអីខ្លះមាន please អញ្ចឹងដោយបានខ្ញុំជំរាបខាងដើមពី outline ថាយើងចែកជា3ដំណាក់កាលធំទី1ថានៅពេលដាក់ implant តើមានអីកើតឡើងអាក្រោយពេលនោះចែកជា3តទៀត immediate complications early complications and late complications during implant placement we mean failure in placement or lack of permissibility or initial stability the same incorrect angulation or malposition devitalization of adjacent teeth មានន័យថាអាចដាំប៉ះទៅលើជើងធ្មេញជិតខាងធ្វើឲ្យធ្មេញជិតខាងងាប់ devitaliser in France in French ខ្ញុំរៀនបារាំងពីលោកគ្រូ fenestration មានថាវាដូចធ្លាយដូចបើកបង្អួច fenestrate ក្នុងភាសាបារាំង fenet មកពីពាក្យ fenet បង្អួចតូចៗវាធ្លាយនៅចុងពិសេសនៅចុង implant ពេលដាំទៅduring implant placement តទៀតថាអាចមានធ្លាយ sinus នៅពេលដាំខាងលើ displacement of implant into the sinus អាចរុញចូលទៅក្នុង sinus មាន case បង្ហាញជូននៅពេលក្រោយ injury to the nerve is a nightmare នឹងនិយាយថាដូចសម្បត្តិអាក្រក់ខ្លាំងមែនតើយើងដឹងជួនថាអាចធ្វើឲ្យស្ពឹកមួយជីវិតprimary hemorrhage យើងចែកថា bleeding ជា primary and secondary មានន័យថាហូរឈាមភ្លាមក្រោយដាក់នៅពេលកំពុងដាក់ឬក្រោយដាក់ពី3ម៉ោងហើយនឹងអាចពី3ថ្ងៃឬក៏មួយសប្តាហ៍ក្រោយនៅហូរឈាមក៏មានដែរមានជួប case ហ្នឹង implant too short into a deep osteotomy site មានន័យថាយើងខួងទៅវែងពេកដល់ដាក់តាមខ្លីមានថាដល់ជំរឿអាហ្នឹងក៏មានបញ្ហាអាច loose ដែរ fracture of the bone aspiration of implants ក៏អាចកើតឡើងក៏តែវាកម្រអញ្ចឹងបន្ទាប់ពីចូលដល់ category TB មានន័យថា immediately after the placements hours to days មានន័យថាគាត់ក្រោយប្រហែលម៉ោងរហូតដល់ថ្ងៃមានន័យថាអាចដល់5ថ្ងៃឬ7ថ្ងៃអាចមានអីកើតឡើង secondary hemorrhage អាចដូចខ្ញុំបាននិយាយមិញថាអាចហូរឈាមដែរមាន ecchymosis យើងឬក៏ហៅ bruising ជាប់អីចឹងអានឹងត្រូវ inform មុនដែរអាចកើតឡើងទៅលើអ្នកដែលមានស្បែករលោងខ្ចីគេហៅ teenagers and old patients អាចកើតឡើង nausea and vomiting អាចក៏មានកើតឡើងដោយសារថ្នាំយើងឲ្យខ្លាំងពេកទៀត anesthetic ដែលមាន codeine ខ្ពស់ពេកក៏អាចធ្វើឲ្យក្បួនចង្អោរឬក៏អ្នកជំងឺអាចលេបឈាមចូលនៅពេលគេក៏អាចធ្វើ nausea ព្រលឹមឡើង stomach ache and diarrhea because of the side effect of antibiotics or antibiotics colitis sometimes, like for example clindamycin can cause diarrhea also with some patients. Weeks to months later, or we call early complications, mean wound adhesions, pretty common, infection, sinusitis, failed osseointegration, soft tissue recession, sensory disturbance because of nerve injuries. Then years later, late complication, bone resorption, you might encounter implant mobility and loss or failed implants, implant displacements, still some implants close to the sinus might displace into sinus years later. Loosening of abutment screws also pretty common. Abutment screw fractures, bridge framework fractures, and implant fractures. You see some more cases at the end. ឥឡូវខ្ញុំសូមចាប់ផ្ដើម detail បន្តិចអំពី during តើវាអាចមានអីកើតឡើង during implant placement វាអាច fail in placement ហើយមាន incorrect angulation អីបន្តសូមពន្យល់មុខទៅទៀត inadequate adaptation aesthetic problems នេះទាក់ទងនឹងថាអ្នកជំងឺអាចមាន3ចំណុចនេះថាអ្នកជំងឺអាច concern នឹង aesthetic យើងមាន case មួយគាត់មក low ជិត10ដងនៅអត់ទៅចិត្តយ៉ាងតិចប្រហែល phonetic problems មានថាគាត់ថាដាក់ទៅដូចទឹងដាននិយាយអត់ច្បាស់អីណាបន្ទុកថ្មីមាន and psychological problems អ្នកជំងឺដែលមានបញ្ហាផ្លូវចិត្តអាចប៉ះពាល់ដែរ ឥឡូវចង់និយាយ during implant placement នៅពេលតាំង no treatment plan radiographic assessment អាច fail ដោយសារអត់មានបានធ្វើផែនការត្រឹមត្រូវសិក្សាត្រឹមត្រូវធ្វើដូចខ្ញុំនិយាយថាអាម៉ារ៉ាតុនដាំជ្រុំយកហ្មងមានន័យថាអត់ច្រើនអត់គ្រប់គ្រាន់ទាំងកម្រាស់ទាំងកម្ពស់ទាំងគុណភាពមានន័យថាខ្លះវាទុនអីពេក lack of initial permissibility មានន័យថាវាអត់រឹងតាមទៅមួដោយអត់តាំងដៃខ្មែរថាមួអត់តាំងដៃអានឹង primary stability or initial stability patient doesn't feel well or too nervous អាហ្នឹងក៏យើងអាចជួបអ្នកជំងឺភ័យខ្លាចខ្លាំងពេកចង់ស្លាប់នៅឬក៏អី candidate for sedations Tony and I have been doing a lot of sedations for apprehensive patients ស្រូវតែដាក់ sedation ដាក់សណ្ដំអីទៅបានអាចធ្វើកើត to prevent the failure នេះសំខាន់យើងថាការពារដើម្បីមុនកុំឲ្យហេតុការណ៍កើតឡើងការពារប្រសើរជាងព្យាបាលមូលហេតុតើយើងដឹងមូលហេតុយើងអាចការពារបានខាងនេះគឺខាងការពារខ្ញុំចង់ចូលទៅខាងនោះអត់ចេញមិនទៅនេះអត់ការនឹងថយទៅវិញទៅចឹងដូចថាអត់មាន treatment plan យើងដើម្បីការពារត្រូវធ្វើ treatment plan ឲ្យបានល្អខាងនោះimproper radiographic assessment យើងត្រូវតែពិនិត្យradio នោះឲ្យបានត្រឹមត្រូវអង្គុយចិត្តចង់ថាពិនិត្យបច្ច័យខ្មែរថាពិនិត្យចែកបានត្រឹមត្រូវចំណាយពេលយូរពេកដើម្បីសិក្សាអំពី radiography នឹងលើ field នឹងឲ្យបានច្បាស់ inadequate bone quantity and quality យើងធ្វើមិនត្រូវមាន bone stock ទិញក្រុមហ៊ុនឲ្យបានច្រើនទៅពីថ្ងៃនេះទៅជួយសាយពាណិជ្ជកម្មឲ្យក្រុមហ៊ុនមកតែចូលនេះឡើងក្រុមហ៊ុនឲ្យជួយសាយពាណិជ្ជកម្មមានអីទៀត broken implants dispenser or motor អាច check យើងត្រូវមុនចាប់ដើមឲ្យធ្វើ check មើលតើម៉ាស៊ីនយើងដើរអត់ស្ទើរអ្នកជំងឺឡើងទៅអីថ្មីនេះម៉ាស៊ីនអត់ដើរ motor អត់ដើរអីអត់ដើរមានកើតឡើងដែរអានឹងខ្មាស់គេដែរឲ្យតែស៊ីក៏រៀបចំសាកមើលឲ្យហើយយើងនាំមកទេហៅក្រុមហ៊ុនខ្ចីយកមកគាត់ថាអូខាងនោះខ្ចីបាត់ហើយចាំអាទិត្យក្រោយអត់មានអីប្រើទៀត Patient doesn't feel well nervous that sedation if you can't do sedation refer បញ្ជូនមកអ្នកចេះធ្វើ sedation then គាត់នៅសង្ខេបដើម្បីថាដើម្បី Children complication, you plan well, prepare well, and then prevent the complications. What can go wrong? Incorrect angulation កើតឡើងច្រើនឧទាហរណ៍តាំងមួយទៅលិចមួយទៅកើតជំនាន់20ឆ្នាំមុនទៅទៀតអាចមានបញ្ហារឿងថាប៉ះថ្មិញជិតខាងធ្វើឲ្យថ្មិញជិតខាងងាប់ក៏អាចមានហើយឈឺរហូតទោះបីយកសរសៃហើយក៏នៅឈឺដោយសារវាមាន pressure ទៅលើ periodontal ligaments នៅអ្នកជំងឺថាដូចបាក់ឈឺចាក់ថ្មិញនៅពេលចាក់ថ្មិញហ្នឹងមានអីសៀតនៅជិតថ្មិញហ្នឹងនៅខាងក្នុង very uncomfortable ចឹងត្រូវដោះ implant នឹងចេញ implant ទៅយកចេញពីគេដាក់នៅសាលា case ពីច្រើនដល់ប៉ុណ្ណឹងខ្ញុំធ្វើខ្លួនឯងគេ refer មកខ្ញុំមកជួយដោះមួយអាទិត្យប៉ុន្តែនៅមួយចេញតែសារវាតូច6ហ្នឹងអានឹង mini implant សម្លយមួយចេញទៅincorrect angulation មួយទៀតគឺឃើញដាក់វាចមកខាង distal ពេកហើយបាក់មកខាង buccal ពេកទៀតនៅពេលខាងពុំមកយើងដឹងដល់ដាក់impression coping ទៅបានឃើញដឹងថាវាចេញឯងបាក់ចង្អាឡយបានវានឹងអត់ទៅបាទមកនេះដែលថាប៉ះពាល់ទៅថ្មិញជិតខាងហើយខំធ្វើ root canal treatment ឲ្យហើយអ្នកជំងឺនៅតែថាអត់បាត់ឈឺដោយសារវាប៉ះគៀបមែនតើយើងធ្វើ periodical X-ray បានឃើញច្បាស់ហើយនឹងប៉ះទៅថ្មិញជិតខាងដូចថ្មិញលេខ41នោះទោះបី root canal ហើយក៏ patient complain ថានៅ very uncomfortable แล้ว move on ទៅ amal position ហ្នឹងមានន័យថាអាចប៉ះពាល់ដល់ aesthetic ទៀតបាទយើងមើលឃើញនៅក្នុងរូបភាពនេះវានៅពេលដែលទោះបីធ្វើ angle abutment ស្បែកក៏ដោយប៉ុន្តែនៅតែខាង technician គាត់ត្រូវការចោះអញ្ចឹងដើម្បីឲ្យយើងនៅពេលដែលវាលំscrews នៅក្រោយពីនេះយើងត្រូវអាចរឹតឲ្យបានចោះរុនពីក្រៅដល់ចោះរុនពីក្រៅបិទ compositor យូរទៅវាចេញ stage ចឹងនឹងគាត់ថាថតធ្វើលុយអស់រាប់ពាន់តែធ្វើទៅវិញឲ្យខ្ញុំចេញចឹងគេតទៀតដោយរូបភាពនេះខ្ញុំយកពី internet ទេថាតាមមកខាង two buckling place influence also affects the aesthetics and prosthesis loss of also in this case the same two buckle ចឹងយើងត្រូវដាំឲ្យ more palatal នៅថ្មិញលើមុខបានល្អបាទ move on please ចឹងដើម្បីការពារកុំឲ្យវាខុស angulation ហ្នឹងគឺវិធីនេះល្អដែលខ្ញុំប្រើយូរហើយគឺយើងដាក់ drill ទី1 pilot drill ដាក់ពីទី1ចូលទៅថតមើលទៅ first drill ហ្នឹងនៅពេលដែលវាអត់ត្រូវ angulation យើងអាចរេបានអត់តហួសពេលយើងរេទៅឆ្វេងទីស្ដាំទៅ more medial or distal បានហើយបាន please move on យើងអាច adjust angulation បាននៅកន្លែងក្បែរ vital structure such as maxillary sinus can also use the guide pins ដាក់មើលទៅតើវាគៀកឬក៏ជម្រៅតាមណា same as mandibles យើងអាចប្រើ guide pins ដើម្បីមើលថាវា parallel អត់តែយើងអាចប្រើ devices ដូចជា parallelist យើងអាចដើម្បីឲ្យមាន parallelism យើងអាចប្រើនឹងភាគច្រើនខ្ញុំអត់ដែរមាន surgical guide លើអាចដាំបិទភ្នែកបើមិនមានអស់តែបើយើងអត់សូវមាន experience យើងអាចប្រើ surgical guide ពិសេសបងប្អូនដែលទៅចេញគាត់ទៅដាក់ទី1ទី2យើងមាន surgical guide វាប្រកបអូខេthen failure in implants placement or ចូលដល់ lack of predictability or initial stability ម្ដងplease next slide អាចបណ្ដាលមកពីយើងខួងធំពេកឆ្អឹងហ្នឹងហើយពេល drilling គេចែកចេញគេហៅ drilling resistant មាន3 type classification of Dr. James, something from Hong Kong, has published in a journal that we can't tell how the classification of D1, D2, but when we drill, we can feel the resistance. Chẳng những đăng thạc, chẳng nâng những chạy trên kìa categorize only three, soft, medium, and hard. Nếu bây giờ drill chóng, nếu bây giờ chẳng tốt, ưu tiên thay tới đăng 4.5, nhưng ở drill đòn lên, drill nâng 4.5, đã tất đơn tạo những permissibility. Khi tới ở tàu chiếng 2 mm này, drill nông. Tại bởi chẳng nâng rừng, very hard code, you have to use cortical drills. Nó kia tới cũng đi thông chiếng tiếp mình, bàn tàn tất cả. Nó bây giờយើងចឹងពេលmìnhយើងទៅដៃនឹងរាវប្រកែស្ទាបប្រកែអីប្រកែដឹងអស់ដូចលោកគ្រូលីសាប្រកែ dexterity in English ថាដៃនឹងយើង feel ទៅ incorrect taping មានន័យថាយើង taping ជួនកាលខុស over taping ក៏អាចបូតគេឲ្យដាក់ត្រឹម35 Newton លេង65វាអាចខូចចាំឬក៏ស្ទើរ too low insertion torque នេះស្ទើរឬក៏ too high torque ក៏អាចមានបញ្ហា oversize also មាននេះគាត់ជាអាចមាន gap between bone and implant so no permissibility so what can we do when there's no initial permissibility មានវិធីថាបើសិនជាដាក់ទៅវាអត់នឹងអត់ជាប់តើយើងត្រូវ remove implant ក៏ reinsert a larger size វាមានវិធីនឹងពីច្រើនបើយើងដាក់អាលេខធំជាងdiameter ធំជាងអាចនឹងបើសិនជាឆ្អឹងនឹងមិនសូវជាទន់ខ្លាំងអញ្ចឹងតើយើងមាន stocks មានន័យថាពេលថាយើងដាក់ implant ដល់មួយគ្រាប់យើងត្រូវ order អាលឿននឹងទុក1 2ស្គួរហើយព្រោះទុកចិត្តអីបុគ្គលិកក្រុមហ៊ុននឹងគាត់មកយកមកជាប់ផ្លូវ1ម៉ោងមកអត់ហត់ហៅតាម telephone នេះងាយយូរទី stock ទុកអញ្ចឹងជួយសាយពាណិជ្ជកម្មឲ្យក្រុមហ៊ុនលោក implant ទៅ stock ម្ដង20 30គ្រាប់ទៅរហូតហើយបោះធុបនអស់ព្រោះអាច fail ដែរគឺការអត់ទៀងទីហោ case នេះចាំរហូតដល់2ឆ្នាំឲ្យជិត2ឆ្នាំដោយសារ COVID យើងណាត់មកថា4ខែ6ខែមកថតទៅគាត់ថាអត់ហ៊ានមក COVID ដល់ជិត2ឆ្នាំយើង expect ថាឆ្អឹងនឹងរឹងប៉ុន្តែនៅតែអត់រឹង2ឆ្នាំខ្លាច COVID ឲ្យយើងទៅសាញ៉ាំអីគ្រប់គ្រាន់តែយើងអត់ធ្វើមិនខ្ញុំញាត់ graph ទៅសិនយកលុយមកលាក់សិនយើង pack បង graph សិនទៅមានពួយដូរលេងនៅអត់ជាប់ហើយទៅមានរ៉ាប់ចាប់ធ្វើក្រោយ6 ឬ8ខែក្រោយទៀតអាសេះមួយម្ដងទៀតបាទទៅមុខទៀតចូលដល់ fenestration of implant site ថាធ្លាយនៅចុងនៅខាងចុងហ្នឹងតទៀតនិយាយថាតើយើងត្រូវធ្វើម៉េចហ្នឹងយើងត្រូវទៅ graph ហើយនឹង GBR មានន័យថា the problem is for flapless or punch ជួនកាលយើងមានបញ្ហានៅពេលយើង punch យើងថា implant ចូលកោបោតែអត់ដល់ស្ទាបទៅប៉ះ implant នៅចុងអាហ្នឹងវាធ្លាយอยู่កន្លែង concavity វា port នៅចុងអញ្ចឹងតើយើងថែម graph នៅកក៏ស្ទើរទៀត case មួយគឺ immediate implants មកខាងខ្ញុំបើក flat មកខាងបើក flat ដោយសារអីនៅពេលដាំហើយ next slide please យើង feel នៅពេលកាត់យើងដកចេញយើងធ្វើ hydraulic dissection នៅពេលកាត់ថ្មិញកន្លែង tips មានន័យថា clay យើងអត់កាត់ទិស horizontal ទេខ្ញុំកាត់ទិស vertical ដោយសារបើយើងកាត់ horizontal យើងយក elevator ទៅបំបែក buccal bone fractures អាចបែកហើយកាត់ទិសនេះវាពឹងទៅខាង mesial distal អត់ទេអញ្ចឹងយើងការពារកុំឲ្យបែកអាខាង buccal ទៅកាត់ចេះទិសប្រឈមបានយើងអាចយករូបនឹងចេញបានក៏ចឹងតើយើងរៀនតាមជនពិការភ្នែក feel គេអានអក្សរបានដោយស្ទាប យើងគិតថាប្រកែអញ្ចឹងយើងរៀនស្តាមថា feel មើលលើកន្លែងយើងដាំហើយតយកម្រាមដៃចុចមើលថាតើអាច feel implant បានអត់ feel ទៅប៉ះ implant បានទៅមាន fenestration នឹងមែនគឺយើងបើក flap ម្ខាងហើយយើងឃើញ exposure of the implant next ទៀតកនឹងទៅគឺ GBR វាមានន័យថាដាក់ membrane sutures នេះជា case ដែលនៅសាលាប៉ុន្តែដាំមក Neo Biden នៅកូនចំដក implant ជួយសាយនីកម្មប្រព័ន្ធមួយទៀតបងប្អូនល្អហើយមិនមកពី implant មកដល់ next slide please locally membrane also pretty common ដោយសារអាចមកពីអ្នកជំងឺឬមួយអាចមកពីគ្រូពេទ្យអ្នកជំងឺដែលងាយនឹងធ្លាយអាចមាន chronic sinusitis គាត់ធ្លាប់មាន sinusite ពីមុនធ្លាប់មាន pathology ផ្សេងដូចជា polyps ស្អីហ្នឹងអាចស្ដើងមែនតើស្ដើងជាងដឹងថាស្ដើងនេះអាចគាត់បើកគាត់យើងថ្នមហើយក៏អាចធ្លាយអញ្ចឹងទៅ assess move on next slide ទៅនេះទៅយើងឃើញស្ថិតិដែលគឺ study នៅ Korea South Korea មានប្រហែលជា 12% ដែលធ្លាយ sinus membrane sinus ប៉ុន្តែ mean តួលេខជាមធ្យមនៅចន្លោះ 25 ទៅ 30% តែនៅយុរ៉ុបប្រហែលនឹងដែរ 24% study បានបង្ហាញថាស្ថិតិដែលធ្លាយ next please តើបើនៅពេលធ្លាយយើងត្រូវធ្វើម៉េច immediately removal has to be done ធ្លាយដល់យក implant ចេញអញ្ចឹងវាអាចមាន foreign body reaction មាន sinusitis អញ្ចឹងដើម្បីការពារយើងត្រូវតែធ្វើ lateral window open អីហើយយើងលើក sinus augmentation and then graft កុំទុកចិត្តថាទៅលើ X-ray ខ្លះវាមានការ distortion តែ angulation យើងដាក់អត់ទៅឃើញដូច sinus floor ឃើញដូចនៅខ្ពស់ពេលថតតែដល់ថតក្រោយទៀតឃើញដូចខ្លីឃើញដូចគៀកពេលថតដាក់ angulation ខុសគឺឃើញអា sinus floor នោះគឺកម្ពស់វាខុសគ្នាបាត់អញ្ចឹងកុំសូវទុកចិត្តលើ X-ray ដល់ 3D អាចទុកចិត្តប៉ុន្តែតាមប្រព័ន្ធយើងអត់ជួនកាលយើងអត់បានថត 3D ទេនៅខាងចេញអូខេ next slide ដូចក្នុង case នេះអាចធ្លាយអញ្ចឹងបើធ្លាយតូចតាចយើងអាចបើ membrane បានអត់អីទុកឲ្យក្រាបទៅឲ្យដាក់ implant បាននៅពេលតែមួយ case នេះធ្វើ sinus lift ដែរតែនៅតែដាំខ្លីពេកក៏អត់អាចជាប់ដែរបើបាន lift ហើយតដាក់ប្រវែងបែប10អានេះបានបែប8នេះដល់ពីមើលមិនទេ10ឬក៏11 12ទៅចូលលើកឲ្យ next slide អញ្ចឹងយើងពីច្រើនចេះខ្ញុំគិតថាពេលនេះយើងចេះធ្វើ sinus lift មាន procedure ច្រើនតែដើម្បីការពារកុំឲ្យមានបញ្ហាឃ្លៀងដល់យើងរៀនបន្ថែម course ខ្លីៗនឹងទៅដើម្បីដូចអ្នកគ្រូស៊ីមនេះគាត់មានបើកនៅផ្ទះជួយផ្សាយគ្រូស៊ីមមួយទៀតគឺមាន sinus lift ជួយតឲ្យច្បាស់នឹងតើពេលណាយើងត្រូវធ្វើ delay ពេលណាធ្វើ immediate អីសំខាន់ដែរទីទៀតនឹងមាន case មួយថាបើសិនជាឆ្អឹងតិចជាងប្រហែល 4 ដល់ 5 មីលីម៉ែត្រយើងមិនអាចធ្វើ simultaneous sinus lift ទេទៅ delay មាន graph ហើយចាំ 6 8 ខែក្រោយចាំតាម implant អាហ្នឹងល្អជាងតែបើបានខ្ពស់ជាង 5 ទៅ 6 មីលីម៉ែត្រអាហ្នឹងយើងធ្វើ lift ដាក់បាន 10 sinus lift ទៅចឹងtechnique អស់ហ្នឹងគឺបានឃើញច្រើនរឿង sinus lift ថាធ្វើមិនពេល drill កុំឲ្យធ្លាយដល់ bone ធ្លាមgive cheerful less risk of perforation than normal bursts តាមទឹក gently push នឹង តាម study ថា piezo is likely to cause less likely to cause sinus perforation piezo law. Okay, next slide. Previous research with the use of piezo say the membrane perforation rate reduced from 30 to 30%. បានច្រើនតែបថយអាធ្លាយនេះបានប្រហែល30ទៅ37%. Okay, ចូលដល់ displacement of implant to sinus interesting ឥឡូវចូលដល់កន្លែងដែលយើងមានថានៅពេលគឺ sinus lift ទៅ open window ទៅជា open door បើតើមួយឥឡូវវាធ្លាយដល់ទ្វារដោយសារវាឆ្អឹងពេកពេកទៅ sinus lift រុញ implant ចូលទៅក្នុង sinus plus ដល់តែយកចេញដល់បើកធំចឹងដូច cover lock approach បើកធំសាក់សិនចេញមកនេះគេcover lock approach or intraoral osteotomy ពាក្យបាលីអង់គ្លេសមានពីរបែបបើក window នឹងចឹងto prevent displacement into sinus និយាយខ្ញុំជំរាបវិញមិនហើយថាគឺ two stage ឆ្លជាបើសិនជា bone នឹងវាស្ដើងពី two stage graft បានលុយ2ដងទៀតទៀតfox មានន័យថាសំខាន់ដែលអាចមានតាក់ទងការផ្ដឹងផ្ដល់ដល់ជីវិតmìnhយូរទៀត next please ស្ថិតិថាមានប្រហែល 7% នៅប្រទេសជាលឿននៅប្រទេសកំពុងអភិវឌ្ឍអាចខ្ពស់ជាងនេះតទៀត so nerve injury នេះគេធ្វើ study ថាបើសិនជាក្រោម9ខែអ្នកជំងឺមានភាពប្រសើរឡើងមានន័យថាអាស្ពឹកនឹងវាថយចុះម្ដងតិចបើក្រោម9ខែអាចមានសង្ឃឹមថាដឹងឡើងវិញទាំងអស់ប៉ុន្តែបើលើសពី9ខែ no hopes or hopeless the prognosis is bad if over 9 months ចឹងគេធ្វើ assessment មួយខែម្ដងអីដើម្បីដឹងថាតើប្រសើរឡើងអត់ហើយមាន study មួយទៀតមានជាថាប្រហែលជា 50% risk of nerve injury ដោយសារមាន bleeding នៅពេលធ្វើនឹងអាចមាន hematoma មានអី compressed on the nerves ធ្វើឲ្យ nerve នឹងមានស្ពឹកអីចឹងដែរហើយនឹងទៅលើអ្នកជំងឺដែលមាន bone resorption or atrophy ខ្លាំងគៀកនឹង nerve យើងត្រូវតែធ្វើការសិក្សាពី radio នឹងឲ្យបានច្បាស់ដើម្បីការពីព្រោះថានៅម្ដុំ mental nerve វាមានគេហៅ anterior loop នេះគឺ anterior loop នោះមានន័យថាយើងមើលអត់ឃើញនៅក្នុង X-ray ទេរៀងដូចអន្ទាក់អា loop នោះរៀងដូចអន្ទាក់វាកោងមកមុខបែរមកមុខឬបែរមកក្រោយអញ្ចឹងឃើញរុននៅក្រោម second premolar ទីអប៉ុន្តែ anterior loops វាខិតមកមុខ first premolar to canine ទៀតអញ្ចឹងអាចប៉ាន់ស្មានខុសបាទអត់តើគេធ្វើការវាយតម្លៃ assess ឬ evaluate ទៅលើ anesthesia ដោយរបៀបណាមានវិធីច្រើនប៉ុន្តែវិធីដែលស្រួលគឺ pinprick test យើងអាចប្រើបញ្ជុល anesthesiolocal ខាងចុងខាងមកខាងទៀតឲ្យអ្នកជំងឺបិទភ្នែកហើយយើងធ្វើតែមើលតើគាត់ដឹងអត់ចាក់មើលហើយគេម៉ាកនៅលើកន្លែងដែលអត់ដឹងចុចបិចអីទៅឲ្យថតរូប review 2ខែ3ខែទៀតបើកន្លែងដែលស្ពឹកនឹងវារួមតូចយើងមានសង្ឃឹមឈប់អត់ធូរតែបើវានៅដដែល6ខែ9ខែស្អែកដោយនឹង hopeless នេះខ្ញុំមានវីដេអូឃ្លីបខ្លីមួយសួរគាត់ថាដឹងអត់ថានៅដឹងនៅដឹងថានៅដឹងអានេះមានសង្ឃឹមមកអត់អីthen មានគេមាន protocol ថាបើសិនជាស្ពឹកឲ្យយើងត្រូវធ្វើម៉េចកន្លែងនេះខ្ញុំថាសំខាន់សូមតទៀតតើ treatment protocol គេធ្វើយ៉ាងម៉េច consultation ទី1 reassure the patient ភាសាអង់គ្លេស reassure និយាយលួងកុំឲ្យគាត់ភ័យពេកអត់អីភ័យពេកនេះគឺការគេអត់លួចអាបញ្ហាផ្លូវចិត្តអាជំងឺស្រាលទៅជាធ្ងន់មកទៅជាធ្ងន់បាទអាស្ពឹកតិចតួចទៅជាស្ពឹកខ្លាំងយើងគិតទៅថា neuronesis and អីមួយទៀត3បល័យអង់គ្លេសនឹងរៀងពិបាកចាំតិចកម្រិតទី1មានថាប៉ះពាល់តាស្រោមរបស់អ្នកហ្នឹងទេអ្នកនឹងមានស្រោមវាបើថាដាច់ត្រឹមសន្ទាប់ទី1វាអាចមានសង្ឃឹមសន្ទាប់ទី2ទៅឡើងទៅរៀងសង្ឃឹមតិចបើដាច់ទាំងស្រុងមកអត់ឡើយសង្ឃឹមអញ្ចឹងគេប្រើអីបើភ្លាមនៅស្ពឹកក្នុងរយៈពេល36ម៉ោងគេអាចឲ្យ dexamethasone ព្រោះអាចបន្ថយការហើមវាបន្ថយ pressure ទៅលើ nerve 4 mg per meals apply គេអាចធ្វើ topical apply 1 to 2 meals 1 to 2 minutes នៅក្នុង studies ឆ្នាំ2013 medication ចាគេឲ្យអីខ្លះបើម៉ែថា ibuprofen 400 ទៅ600 mg មួយថ្ងៃ3ដង TID means 3 times a day or every 8 hours for 1 week. Moderate dexamethasone oral 4 mg, 2 tablets in the morning, 3 days, and 1 tablet in the morning after the next 3 days. គេឲ្យដំបូងគេឲ្យដូររៀងខ្ពស់ក្រោយមក3ថ្ងៃដំបូងថយពេលប៉ុន្តែអ្នកឈឺកាពះឲ្យបានអានោះវាប៉ះពាល់កាពះបាទតទៀតពេញថ្នាំផ្សេងទៀតដែលគេអាចឲ្យគេប្រើដូចពួក diuretics មាន vasodilators B group vitamin B are commonly prescribed យើងប្រើច្រើនណាគឺគ្រូគាត់ឃើញប្រើច្រើនពួក B complex B complex ដូចជា neurobion fork មាន neurorubin fork ក៏បានអានឹងគេឲ្យពីមួយថ្ងៃតែមួយម្នាក់2អាទិត្យឬអាចយូរជាងនឹងក៏បានដែរពួក vitamin B គេឲ្យដល់3ខែបើសិនជាអ្នកនៅថាពជានៅតែស្ពឹកមិនបាច់អា fork ក៏បានដែរបើឲ្យដល់3ខែឲ្យអាធម្មតា fork នេះវាដូរស្ពស់ antihistamine ក៏គេធ្លាប់ឲ្យ10 mg អីចឹងទៅតទៀតពីបើសិនក្នុងករណី complicated cases ប៉ះពាល់ដល់ផ្លូវចិត្តគេអត់លួចទេគេឲ្យពួក antidepressant amitriptyline anticonvulsant Tegretol ក៏គឺគ្នាយើង prescribe ច្រើនដែរបើមិនដែលយើងការត្រូវយើងការអត់ត្រូវដោយអ្នកជំងឺអត់មានថាគ្រប់គ្នាត្រូវទាំងអស់រឿងថ្នាំពួក anti sympathetic agents ក៏គេធ្លាប់ប្រើ physiologic therapy or physiotherapies is good អាចប្រើបានគេធ្លាប់ប្រើជួយ stimulate the nerve acupuncture sometimes laser មានទៅតាមប្រទេសដែលគេប្រើនេះគឺ study នៅ Japan គេមានstep ទៅតាមនឹងដែរដល់ប្រើ stellate ganglion block steroid vitamin B and near infrared radiation in techniques ខុសៗគ្នាnext please នេះគឺថ្នាំដែលថាយើងនិយាយមិញនេះមាន neurobion fork គេឲ្យ 2 to 4 tablets in divided doses per day មិនបាននិយាយ dose នឹងហើយexam ស្គាល់ពួកខ្ញុំធ្លាប់ជួប case ដែលមានក្បែរក៏អាចធ្វើឲ្យមាន pressure ទៅលើដល់ដែរចិត្ត mental foramen ហើយនឹង case នេះគេដាក់ទៅសាលាយើងមើល canal អានោះចង់ចូលដល់នោះអត់ក្បែរអាធំក្រៅទី2នោះគឺហួរឲ្យទី3រាប់ពីក្រោយនោះក៏ចឹងដែរគឺតែគៀកមែនតើដែលធ្វើឲ្យមាន prestige for quite a long time ហើយនេះ canal next please stop មកទៅចឹងដើម្បីការពារភិនតដែលដាក់ជីនកាយចូលទៅថតបើសិនជាថាយើងចូលហើយនៅពេលដាំបន្ថយវិញដូចខាងដាំបន្ថយបានអាចបន្ថ là từ những gì mình đi họ case này là những đam thà những kia cần lẽ lại cái bốn kia khối có những thoi với những thứ nhà muốn quen đam đi khối đại đi thưa thông chim tích tay khởi nâng những ai chim những bạn những cái lo chim 3D nên thế và những trong cho bạn ở khác khơi thảo việc kiện nơiของรัฐนะคือnhững thứ CD or CBCT ទៅយើងអាច identify the canals ទីហោក្នុងករណី case នេះយើងឃើញគៀកពេកដោយសារគឺ crystal flattening មានន័យថាឆ្អឹងគាត់ស្រួចខាងលើដូច nice edge គេហៅ nice edge ឬក៏យើងថាមុខកបិតវាស្ដើងយើងថាមុខបថៅវាស្ដួយលើអញ្ចឹងយើងកាត់ពីលើបែប 2-3 មីលីម៉ែត្រចុះមកដើម្បីដល់ក្រាស់យើងអាចដាំបានតែវាត្រូវថយកម្ពស់អាចគៀបនៅអញ្ចឹងវាអាចប៉ះពាល់ដល់តែ case មួយនេះក៏មានប៉ះនៅខាងឆ្វេង number 34, and I mean quite close to the nerve. But luckily the patient has got temporary paresthesia, a few months only, not that long. Case នេះបានបញ្ចប់ដោយជោគជ័យដែលអត់មានបញ្ហាស្ពឹកអីទៀតឲ្យខ្ញុំឲ្យ neurobion នឹងដែរឲ្យ neurobion vitamin B នឹងដែរជួយដល់នេះខ្ញុំបានរៀបរាប់វិញគាត់ថាយើងថតវិញមុននេះគឺ pinprick test ហ្នឹង 3D ដើម្បីការពារឬក៏មើលតើ implant place នៅឆ្ងាយប្រហែលពី canal ហើយយើងដឹងដែរថាគាត់មានការផលិតគេថាការប្រើ anesthesia local ដែលមានneurotoxicity ខ្លាំងពីពួក neurocane articane អីគេ avoid កុំឲ្យប្រើហើយយើងយកប្រើបាច់ block ប៉ុន្តែ case ខ្លះក៏ block អានឹងដូចគ្នាដែរនឹង sinus ដែរគឺ nerve យើងអាចប្រើ pin guide ហើយនឹងអាចដាំ implant នៅ anterior region ដើម្បីការពារហើយនឹងអាចប្រើ drill guide ឬក៏ stopper and also proper pre-surgical planning diagnosis and treatment are the key to avoid nerve injury គឺគេ claim និង key គឺ parameter claim នឹងយកល្អគឺឲ្យបានចម្ងាយតែ 2 មីលីម៉ែត្រពី nerve បានអងឯកសារខ្លះថា1 មីលីម៉ែត្រគឺគៀបពីលើចូលដល់រឿង bleeding មានប្រហែលច្រើនមានប្រហែល 24% តាម study ប៉ុន្តែមិនមានអីធ្ងន់ធ្ងរវាអាចយើងតាមទៅទីខាង lingual plate cortical plate អាចប៉ះពាល់ដល់ submandibular space that can also cause blocking the airway អាចធ្វើមាន airway obstruction ប៉ះពាល់ដល់ផ្លូវដង្ហើមដែរបើសិនជាមាន bleeding ខ្លាំង push under for the mouth មាន case នៅក្នុង study ឆ្នាំ 2006 ថាមានរហូតដល់ចូលសង្គ្រោះបន្ទាន់ដោយសារ bleeding ក៏តាម implant ខ្ញុំដល់ស្រាប់ពី presentation នៅប្រទេសផ្សេងៗដែលខ្ញុំទៅដូចថតនៅតៃវ៉ាន់ឬកូរ៉េនេះครับថៃប្រកបមាន present រឿង bleeding អញ្ចឹងយើងចង់ start ពី anatomy នៅកន្លែងដែលយើងខ្វាយតាម implant ពិសេស arteries ធំតោះហើយមើលពី anatomy រំលឹកពីហ្នឹងដែរហើយប៉ះពាល់បាទហើយនឹង 3D ដដែលនេះពីយើងទៅទៀតថាយើងដើម្បីការពារថាវាអាចមានប៉ះពាល់ទៅ artery មួយណាគេហាមមិនឲ្យដាំចុះ midline ដោយសារ midline នេះវាមានកន្លែង port កណ្ដាលgenial tubercle កន្លែងអាច port concave ទៅអាចធ្លាយប៉ះអាចប៉ះដល់ lingual artery ដែរអញ្ចឹងគួរជៀសបើជៀសបាន bleeding controls is pretty basic អានេះគាត់ថាយើងអាចប្រើអីក៏បាន មានបច្ចេកទេសផ្សេងៗប៉ុន្តែសម្រាប់ការដាំ implant យើងអាចប្រើ tranexamic acid compressions មាន case នេះមួយដែលអ្នកជំងឺដាំយូរឆ្នាំហើយដំបូងគាត់មានបញ្ហាសុខភាពអីទេប៉ុន្តែដល់ពេលមកដាំលើកទី2មកខាងទៀតគាត់មានប្រើថ្នាំ anticoagulants
ស្គាល់គ្រូដោយសារមកចិត្តអង្គតែសុំ5នាទីទៀត
5នាទីមុខទៅលឿនចុងក្រោយ marathon lecture អញ្ចឹងយើងត្រូវធ្វើឲ្យ test សិនម្នាក់ប្រើ anticoagulant ទៅទៀត implant អាចចូលទៅក្នុងកន្លែងជ្រៅពេកក៏អាច fail ដោយសារ case នេះមាន fail មួយ case contamination មានន័យថាយើងគេហាមមិនឲ្យប៉ះ implant នៅពេលដែលយើងបើកពីកញ្ចក់ sterile នេះវាអាចធ្វើឲ្យ fail ដែរ secondary hemorrhage មិនសូវជួបប្រទះទេយើងឃើញតិចមានក៏ងាយស្រួលក្នុងការទប់ដែរមិនចឹងឡងហើយមិនសូវជឿជាបារម្ភទេ step នេះគឺសំខាន់គឺយើងអាច prescribe tranexamic acid mouthwash បាំង boost acid tranexamic បារាំងភាសាបារាំងដោយសារមានលោកគ្រូនិយាយបារាំងខ្ញុំសូវនិយាយបារាំងបាន suture អីចឹងទៅបាទ apply multiple suture នេះ exacil របស់បារាំងដែលជាបើជាគ្រាប់យើងអាចកាត់ឲ្យមាត់ទៅដាក់ទឹកប្រហែល5-10 មីលីលីត្រកូអាលីអាចបៀនទៅបាទ ecchymosis ខ្ញុំមិនជាសំខាន់ប្រហែលដែរយើងអាចមូលទៅជាប់នឹងអីវាអាចបាត់ទៅវិញក្នុងរយៈពេល2 ទៅ 3 សប្តាហ៍ wound decision បានអាចពិបាកបើសិនយើងធ្វើ bone graft វាអាចក្រាបនឹងរត់ចេញមានប្រហែល 7% អីដែរដោយករណីនេះដែលថាធ្វើ graft អីហើយស្រាប់តែនឹងអាចមាន wound decision មានន័យថាក្រោយយើងដេកហើយប្រហែលមួយសប្តាហ៍រហូតកាត់ជិះប៉ុន្តែមានចំហនៅចំហមានន័យថាអាចបាត់ graft មួយចំនួនតទៀតនេះឧទាហរណ៍ក្នុង case នេះយើងឃើញ expose bone ឬក៏ក្នុង case នោះមានបញ្ហា wound decision សម្រាប់case នៅសាលាឆ្នាំដែរហើយតែគេជូនមក wound decision going after bone grafting bone exposure មានដូចគេហៅ sequelae ឬក៏ bone fragments នៅសល់អីចឹងចឹងដើម្បីការពារអត់ហ្នឹងយើងធ្វើ atraumatic surgery យើងអាចធ្វើ gentle soft handling អីហ្នឹងយើងដឹង infection យើងមិនសូវជួបប្រទះដែរច្រើនតែជួបនៅលើ immunocompromise មួយចំនួនដូច diabetes ដែលមាន case មួយដែល lose implant នៅលើ diabetics patient ចុងក្រោយយើង end up with breach peri-implantitis pretty common យើងខ្ញុំដែរយើងដឹងថាបងដោយសារ bacteria ផ្លាកអ្នកជំងឺអត់សូវមានអនាម័យយើងអត់បានអប់រំអស់អញ្ចឹងចាថា patient education is very important ក៏ដល់ implant យើងឲ្យធ្វើម៉េចដុសសម្អាតឲ្យខ្លួនឯងមានថ្នាំ prohexidine នេះជារូបភាពថា peri-implantitis រូបភាពគឺចាំសដងខ្លាំងនឹង literature ក៏មិនសូវសំខាន់មួយទៀតទៅនេះមាន case យូរហើយគាត់ដាំនឹងយូរឆ្នាំហើយមាន peri-implantitis មានច្រើនដែលយកចេញហើយនៅក្នុង literature អាចបណ្ដាលមកពីលើសស៊ីម៉ងដែលពេលភ្ជាប់ថ្មិញអញ្ចឹងក៏អាចធ្វើឲ្យមាន peri-implantitis procedure អស់នេះគឺអាច works sometimes doesn't work គឺដូច root planning បើក flap អីមកដើម្បីធ្វើ curettage លាងអីហើយដាក់ graft អីទៅវិញជួនកាលអាចមានប្រសិទ្ធភាពជួនកាលអត់ដែរ case នេះមានធ្វើដូច root planning តាំងពីយូរហើយអាចជោគជ័យទៅពេលយើងធ្វើហើយឆ្នាំដែលយើងឲ្យក៏យើងដឹងអស់ហើយថាទីច្រើនឲ្យអស់នឹងហើយអញ្ចឹងមុំទៅអត់អីយើងអស់មកហើយរឿង scientist អីនេះចាំconference លើក្រោយហ្មងប្រហែលតែតចុះក្រោយខ្ញុំសុំ2ម៉ោងនេះហើយ ឲ្យនិយាយ1 ម៉ោងអីវា case ច្រើនអត់កើតនឹង
ចាសូមអរគុណគ្រូសូមអរគុណសម្រាប់presentation ដ៏ល្អរបស់គ្រូតែដោយសារតែពេលវេលារបស់យើងខ្លីមែនតើអញ្ចឹងនេះខ្ញុំសូមអត់ទទួលសំណួរទេបើបងប្អូនមានសំណួរនៅពេល line break សូមអញ្ជើញជួបលោកគ្រូផ្ទាល់ដើម្បីសួរសំណួរហើយបើចាប់អារម្មណ៍តាក់ទងរឿង sign នៅសល់ឆ្អឹងប្រហែលអាចលើកបានសូមជួបគ្នាជាមួយនាងខ្ញុំនៅពេលថ្ងៃចា sign up link ដែរចាអរគុណអញ្ចឹង next I would like to invite Dr. Peace to go on stage and share your presentation with our audience.
Good morning, everyone. Good morning, colleagues and students and invited speakers. And I just want to start the talk, and I might have to rush fast. It's just based on the fact that the oral cavity is easily examined, and the Italian proverb that by letting us look into your mouth, you get to know a person by looking into the mouth. And for the dentist, that's true. You get to know a lot more than because the mouth actually shows us more than we think. Some simple facts: the oral cavity is generally easily examined. It's an important part of our body with specialized tissues and functions, right? We all know the importance of the mouth, and it's involved in some dermatological conditions and also many other conditions that affect some other organ or many other organs. The dentist may be the first one to detect and the possibility of a systemic condition. So that's why it's important, right? So what we can do is not just identify, but help to treat the oral symptoms as well. Occasionally, it's a dentist who is the first person, and he will refer to the medical practitioner, a suitable one. You ensure effective prevention and follow-up of these oral problems, and we want to see them healed as well. So we work with the medical. The objective is just to raise awareness of these various ways in which the systemic conditions can present in the mouth. And I want to stress the importance of taking a good history, because even taking a good history, you would get a lot of information if you do it properly, and then assess the patient well. Make sure you look at the patient as a whole and examine everything thoroughly. Then you will miss things. You will, so start with the gastrointestinal disorders. Some of these may not be familiar, but just to give you an awareness that these things exist, and especially if some may not be Asians, but different races have different prevalence of these things. So just know it, because the world is opening up, and you get all different countries, people from different countries coming here, and you may get the patient in your surgery. Crohn's disease can affect the whole GIT, inflammatory and probably immunologically. It's an inflammatory and also immunologically mediated disease, probably. And it's for it affects young people between 11 and 30 years. They get, this is what they go through, right? A lot of discomfort. They may even be malnourished or anemic. But what we see in the mouth is nodular swellings, cobblestone-like mucosa. I'll show you a picture. And facial lip swellings, on ulcers. Ulcers can happen in many different conditions. So just don't look at ulcers as, just ulcers, but think deeply. Could it be something else? Fibrous hyperplasia, like soft tissue swellings, angular cheilitis, which happens in many conditions as well, and glossitis. So that's the cobblestone-like mucosa and ulcers, different kinds of ulcers, right? And then another condition is Gardner syndrome, also to do with the GIT, intestinal polyposis, is familial. And here we see osteomas, multiple osteomas. So you can ask them further about any other symptoms, and then do the referral as required. Then we hear about acid gastric regurgitation and the reflux, and the pH is 1 to 2, and this can really affect the teeth. So if you examine and see that there are erosions of the palatal lingual surfaces, you need to check, because they may just be not noticing it, and it can be treated if you see the right physician. Halitosis as well goes with that. Then the malabsorption syndromes. These are different, present with different deficiencies. So you get ulcers, bursitis, angular cheilitis again, and sialosis. Right. So this is not so common. We don't see it so much now, but iron deficiency anemia can affect mainly women. It's also a pre-malignant thing. And they get bursitis, dysphagia, and the lesions in the mouth. We need, what was that? Yeah. They have a burning sensation on tongue mucosa, that they can come with that complaint. And just remember that when you see unusual parts of the mucosa, refer to your oral surgeon, maxillofacial surgeons first, because they need to take a biopsy, or if you do biopsies, you can, but it's better that way, because then the treatment and follow-up will be done there, and they refer the patient back to you for further follow-up. Now, pernicious anemia. This one is a deficiency of vitamin B12, cobalamin, and here you get ulcers, bursitis, angular stomatitis, and that happens with quite a lot of deficiencies and quite a lot of systemic conditions as well. So we need to be aware. Blood tests are good for these things. If you suspect anything, send the patient for some basic blood tests, and that can tell us things. This is a syndrome from small intestinal polyps, Busch-Jaeger syndrome. It's rare, but if you see these spots, right? Pigmentation around the mouth and inside the mouth. Like for me, I'm from Sri Lankan origin, and Indians, we do have pigmentation in mouth, but for some races it's unusual. And anyway, if it's something that's of recent onset, we need to take note of that and refer the patient, because they could be high risk for some cancers, and they need to have their GIT checked. So cardiovascular disease as well. Patients take tablets for hypertension, and that can cause lesions in the mouth. So you might think it's lichen planus, but actually it's just a lichenoid reaction to lichen. Listed here, you have lichenoid lesions, dry mouth, gingival swelling, all these, there are a number of drugs actually that cause problems in the mouth. Then you have this one, of course, rarely, but an important thing. If you can't find a reason for pain radiating to the jaw, you can ask for the questions and find out if the patient is at risk for cardiac problem. So refer to the right person, and you can actually help the patient. Giant cell arthritis. This is a very severe headache that patients get, and it's very persistent. It's important that you recognize it. If you find that it's a very something that's started recently and going on persistently, you might want to refer this patient as well, because you can actually save. They could have blindness or even a stroke and death. So it is important. If you see patients with cyanosis and delayed tooth eruption, that could also point to, but for children, some cardiac problem, Fallot's metrology. Endocrine conditions, these are interesting. Example, acromegaly. This is after the closure of the epiphyseal plates. And their age group usually starts in their early 30s. And you don't really discover till they're 40 So at that age group, if you see spaces appearing between the teeth and the tongue appearing a bit large, look at their hands. If they are bigger, feet, you can ask the patient. And if you suspect something is happening like that, and the jaw, of course, is also getting bigger, you can refer them to an endocrinologist just to be sure that they are not having a problem in the pituitary gland. If not treated, there could be very serious complications. Right? They also have sleep apnea. Now for diabetes, we all know periodontal disease, dry mouth, candida. So this you are very familiar with, right? So, and of course what I mentioned earlier about the drugs. Gigantism is before the closure of the epiphyseal plates. That one also similar kind of similar picture, but younger patient. And it may be due to a pituitary tumor. Okay, so this is unusual growth, a child growing larger than they should be, and so you refer early to the endocrinologist, and that can save the parents and the patient a lot of trouble. So this is what we need to be very alert. Don't just look at the teeth and the mouth without thinking something's not right. If you think something's not right, find out why. Hyperparathyroidism. This one we see giant cell. What will be diagnosed as a giant cell granuloma in the jaws, and same thing. When you see this loss of lamina dura in the panoramic, and I can't see where this is going. Do you see the pointer? Yeah, but if I point there, so that's loss of lamina dura, and this, when the biopsy comes back as giant cell tumor, or there's some blood test that you've done with the levels that in the hospital, refer to the hospitals, they will be able to do the right blood test, calcium and alkaline phosphatase and whatever that is relevant. And this can be treated. Once they treat the cause, things will settle. And that's what the histopathology looks like. The jaw will have a swelling, of course, and the tumor will be in there. It's not a tumor, it's you call it brown cell tumor, but it's because of this hyperparathyroidism. Okay, now hypoparathyroidism is congenital. This one, you have calcium level dropping, and so all that happens, the parathyroid, the whole sequence, parathyroid hormone is released, and then it acts on the kidney, and that increases the reabsorption. And finally, if this happens early in life during odontogenesis, the teeth that you see will have pitting, as you see here, and enamel hypoplasia with failure of some teeth erupting. So you can actually refer to the hospital. They'll do the blood test as usual, and then refer the patient. Sorry, I have to go very fast. And that's this is endocrine, hypoadrenocorticism. This one again, you have pigmentation of the oral mucosa. So this is of recent onset. The GIT upset with craving for salt. You need to find out the reason, and then why are they having this? If it is hypoadrenocorticism, we have to treat them carefully. They will need top up of steroids. So it's always good when something's unusual, refer and get a diagnosis. Is there a systemic problem before we proceed to treat the patient? Other endocrine hormonal changes with menopause, osteoporosis, and you take the X-ray, precocious puberty, accelerated tooth eruption, erupting early, fibrous dysplasia in Oeurn syndrome, then there's pregnancy also. You all know about swellings in the gums when the patient is pregnant, and then it will grow, and if you remove it, it will recur. So these are things that we need to understand, and then we can handle patient better. I can't go into detail. So hematological disorders, same thing we mentioned just now about malabsorption syndrome and other things where the absorption is not good. So here it's hematological disorders where something happens in the bone marrow and can affect the other cells. So since this is rare, but it's life-threatening, so it's important to catch it early. If you have ulcers and appearing, and then there's bleeding tendency, there in the mucosa, sudden appearance of purpura, gingival bleeding, petechiae, ecchymosis, anywhere. This is unusual. Although there could be this kind of causes, the important thing is we need to respond well, and we need to know that with this aplastic anemia, everything is affected. They are not just anemic, they have low white blood cells and low platelets, and that explains the picture we see, so we need to refer them quickly, and I'm sure you do that. Hematinic deficiencies, this iron, we mentioned earlier, iron, folic acid, or B12. And these levels can be checked by blood tests. And the patient comes with these kind of symptoms, burning mouth, because we await a hull, they can complain, no, I can't have that kind of food anymore, what's happening? Of course, they are getting older. The people, when we are older, our mucosa is unable to tolerate a hull, whatever it is. Spicy is quite unbearable sometimes. So, but that's not what I'm talking about. Sometimes it's a metastatic tumor or a primary tumor and a malignant one. So always have a biopsy done and sent to the histopathologist, because we can sometimes be surprised at the diagnosis and we need to respond. So you've got the oral surgeons in the hospital to do all this. And for leukemia, patient can present with infections, unusual and difficult to treat infections, bleeding, and also they'll be anemic, right? But this, so I'm moving a bit fast. The treatment is the one that causes all this to change. Because I mentioned up there, treatment is chemotherapy, radiation, and bone marrow. So either you see them before they diagnose the leukemia, or you see them as leukemic patients who are receiving treatment. And so, depending on where they are, you will see these symptoms. Okay, and with these symptoms, you need to have high suspicion that there is something going on, and a malignancy, this is a cancer, we have to respond. So if we find something unusual, make the patient go quickly, tell them it could be something serious, right? That's how it can look like. Swelling in the gums. I think it's oral hygiene. Once I had, this was my personal experience, I had a patient where was bleeding from a tooth all night. And this tooth was firm, it just had an exposed pulp, and the patient was bleeding from that pulp. And the bleeding wouldn't stop. And when we sent for blood tests, there were unusual levels, just anemic, and they examined further and found that she had leukemia. So it's a strange presentation, but it comes to us first sometimes. Inform us. Same thing, presentation, very common. ulcers, mucositis, xerostomia. That's what we see. And sometimes the diagnosis of lymphoma is not made here. So we must send them off to the right person. Thrombocytopenia is when there's a decrease of platelets, so they come with bleeding tendency. It also can happen in an infection, right? You all know that in Cambodia, in Malaysia, what do we have? Dengue fever. When the platelets drop and they have fever, and some of them don't even have fever, and you know that we have to check the blood. It's an important thing. Multiple myeloma, this is, they come in with bone pain and tooth mobility, and also amyloid, it can be involved, affected, I'll mention, associated, I'll mention that later. Cyclic neutropenia is neutropenia, the neutrophils, the level drops, and it doesn't happen, the levels change over a period of time, so they're quite cyclic, it comes back, and then it's normal. So when the patient gets ulcerations, severe periodontitis. So those who dealing with periodontal patients with periodontal problems know that I'm sure you're aware that the periodontal diseases can be a reflection of what's happening systemically. These are the symptoms for cyclic neutropenia, but this diagnosis comes from the medical side when they examine the patient. That's another ulcer, cyclic neutropenia. The ulcer can look like that. Solitary ulcer, even. Solitary ulcer, by the way, since there's not much time, I'll just try and give you the pictures as we go. So a biopsy, sometimes ulcers need a biopsy. Of course, you do your blood test first and all, but if you need to biopsy, and even in Cambodia, there's been a patient come back with diagnosis of TB from this ulcer, and then the patient started to undergo treatment for tuberculosis. And also be malignant depending on the feel of the ulcer, and the surgeons will know how to do the biopsy. When they do the biopsy, they know what they're looking for and how to handle it. Immunological disorders, these skin diseases will also come under here, connective tissue disease and things like that. Sclerodoma is one that can present with to us before others notice it. The face is shiny and tight, so when they open the mouth, you can feel that the mouth is restricted. And there's another condition, there's another condition that's related to chewing betel quid and betel quid, and that is very limited to mouth, not affecting the face. Submucous fibrosis, but that's just the mouth, and that's also related to areca nut and betel quid. So this one is different. It affects the face, it affects other parts of the body. So these two we have to refer. We spot it, we think something's not right, and then we tell the patient there's something we notice, and you explain to them, and then send them to the doctor. Oeurn syndrome. This is an autoimmune condition, also systemic. But what do we see in the mouth? Xerostomia, and they also have dry eyes. And Sika syndrome is when both. You have dry eyes and dry mouth. Oeurn syndrome, even just dry mouth. But they have difficulty swallowing, altered taste, fissured tongue, and atrophic papillae with candida, angular cheilitis, decay of course, dry mouth, decay of the teeth, but the biopsy, this is again where the surgeons in the hospital will, once they see the picture and do some tests, they will want a lateral gland biopsy to confirm the diagnosis. It's not 100% reliable, but it's a help. So what can the dentists how can they have this suspicion? Because these patients, if you ask further, you will realize that they have fatigue and they are not really doing well if you ask further. And the patients you can actually, once a diagnosis is made, we can help support the patient in their oral health because the symptoms are hard to manage on their own. You need to prevent fungal infection and caries progressing further. The two forms of Sjögren's syndrome I mentioned earlier, and I don't think you need to go into detail here. Lupus erythematosus, there's the systemic one as well and just mild one. If it's mild, that's okay, but I mean, the mild one is not worrying, but still a diagnosis is important and the immunologist must be following up the patient, so we need to refer. This is what we see in the mouth. Okay. There are many symptoms that we may see, but whatever it is, there is a high suspicion that this needs to be referred. You can refer to the dermatologist, depending on what the patient presents with. And then you right away to the immunologist. That's the erythematous patches in the mouth. These are all unusual. And if they have those with rheumatoid arthritis, they will have TMJ arthritis with Sjögren's syndrome, and they may have drug reactions. It's all related. Then there's angioedema, it's also an autoimmune. Angioedema, they get swelling like an allergy reaction. That's a facial swelling. So that again, that we detect, we ask the patient, does this happen when you take something or in a certain environment? How often does it come and go? Has it happened before? So if you suspect it's angioedema, you can refer again to someone so they can find out what else is connected to this angioedema and treat them accordingly. Behçet's syndrome is oral ulcers with also eye involvement and maybe genitals as well. Langerhans disease, there'll be changes in the bone, the periodontium surrounding the teeth, and there will be little swellings of the gums. We have had patients in the UHS where we took out the loose tooth, biopsied the gingiva, and the biopsy came back as histiocytosis X. And the child needed treatment and did better with that. Sarcoidosis is another autoimmune disease, xerostomia, salivary gland swelling, and all these syndromes that are related, and oral swellings. Just to give those, I'm going fast, but it's mainly to give you an overview of what you can see in the mouth and relate to different systemic diseases, right? And the importance of referring, catching them and referring. Infectious diseases, there's so many, the bacterial, the viral, the fungal. And for fungal in a child, for candida infection in a baby, toddler, it's in an infant, you don't worry about it, it happens. But in an adult, you want to know why. Is it the denture? Simple reason, or is there some kind of immune compromise state that the patient is in? We want to know. So there's candidiasis, there are white lesions, which can be wiped off, giving a raw base, red lesions, angular stomatitis. Then the Coxsackie viruses that's happening even now in Cambodia. I know someone whose child has the Coxsackie virus. It can be very painful, and it's a notifiable disease, it's hand, foot, and mouth disease. So this you need to refer to a medical colleague. Cytomegaloviruses also cause ulcers and sialadenitis. So if it's a normal abscess, recurrent abscess ulcer, that's fine. If it's traumatic ulcer, we can diagnose that. But then some ulcers, we really need to refer to the hospital and they will sort it out. Epstein-Barr virus in infectious mononucleosis, there's so many symptoms are a lot. Patients are not well with this and they need help. We need to refer them. This is how they come to us. And of course, HIV can present with so many different signs and symptoms. Anything they say unusual, difficult, just ask, take a history, and then you can proceed from there. If you find difficulty, refer to a medical colleague. And for blood tests, or refer to the hospital. The surgeons will know how to proceed with these patients. Liver disorders, patients can have liver disorders from hepatitis, having hepatitis infection, from those who are alcoholics. Different reasons for liver disorders, but it can cause serious problems, and you can see bleeding tendency. We need to know the medical history. We're going to do extractions. And then chronic active hepatitis, they will have lichen planus in the mouth. That's something you need to get from your history before. Because normally we just take lichen planus as lichen planus or a lichenoid reaction, so the history will help us. And then hepatitis C, you have salivary swelling, xerostomia, and lichen planus as well. Patients with liver problem who are having jaundice, that's how the sclera looks. And the hand, the fair skin, you can see the color as well, color change. Metabolic disorders, we have various biochemical processes in our body that helps our bodies keep stable and function well. But if there's some disorders, this is what happens. You have, for example, amyloidosis also can show up in the mouth, deposition of some protein. So what happens is you get this little, there are changes in the mucosa and the tongue, if it's in the mouth. Usually the tongue and the lip just move. Depending on the organ involved, because it's systemic, the process can cause minor changes, as in the mouth, or major problems when it affects other organs. If it affects the heart or the kidney, it can be quite major. So we need to be doing biopsies if it's in the mouth to get the diagnosis. And multiple myeloma also presents in the mouth. That is also detected by a biopsy because you find it affects the bone, and you want to biopsy that lesion. And when the report comes back as multiple myeloma, then the medical colleagues will be involved in managing the patient. And with this multiple myeloma, patients can present with amyloid as well. So depending on which way they come, but we are interested in us being the first one to see something happen in the mouth and the systemic part is not detected yet. So if you see solitary mucosal deficit, we biopsy it in its amyloidosis. We need to be sure that it's just that one thing happening in the body. Is it just that one thing? It's all right, but they follow up the patient, and a medical colleague has to be involved. So this amyloidosis is systemic. You see, it affects mostly older adults. The patient is fatigued. These are other symptoms: weight loss, edema, paresthesia, hoarseness, mucocutaneous lesions. A lot of things can happen, but that's later on. So when we make a diagnosis is when we get the patient referred. That's how it looks like under the microscope. Homogeneous eosinophilic. And these are the deposits. You see in the tongue, it looks like little lumps. or solitary, you know, and then the eyelid area. Okay, rickets. Vitamin D resistant rickets, hypophosphatemia. These, you see, the teeth, primary teeth are already non-vital because they have large pulp chambers and the dentine and enamel, it extends right to dentine and enamel, and so they get non-vital. The unusual is hypoplasia. So those things also, they need to be further. This one, we see that often in dentistry because patient comes complaining of ulcers and around the lip, and if you ask their history, they may have had a recent infection or taken some antibiotics for the infection, and it just happened at that time. So, yeah. Then you have lichen planus I mentioned earlier. Lichen planus, I hope you all know the picture. For some reason I didn't put it in my slides, but it presents with white or red lesions, but you have a striae, and it's usually bilateral, and so normally we can recognize it. Those who are trained will recognize it as lichen planus, but a biopsy is just to prove to the patient that it's lichen planus. And the erosive ones we follow up. It's known as precancer, could progress to cancer, so we keep an eye on those. So I'll end my talk here. Thank you.
Yes, thank you very much, Dr. P, for your very nice presentation. ជា slide session នេះគឺ session អត់សំណួរទេសាពេលវេលាយើងខ្លីតែបងប្អូនមិនទាន់អាចអញ្ជើញទៅក្រៅព្រោះអីយើងមាន special 5 នាទីទៀតចា៎
តែជា chairperson ចំពោះការសម្របសម្រួលកម្មវិធីជាកិច្ចបន្តសូមគោរពអញ្ជើញទៅតាមបណ្ឌិតឯកទេស Phan Sandeth ប្រគល់ certificate of appreciation ដល់លោកក្មិន I would like to invite Dr. Phan Sandeth to present certificate of appreciation to the speaker. សូមគោរពអញ្ជើញសាស្ត្រាចារ្យអង្គសមេតឡើងមកលើវេទិកាដើម្បីទទួល certificate of appreciation. បន្តទៅនេះសូមគោរពអញ្ជើញ President ប្រគល់ certificate of appreciation ជូនដល់ Chairperson. ជាកិច្ចបន្តទៀតនេះសូមគោរពអញ្ជើញក្រុមហ៊ុន Phan ឡើងមកលើវេទិកាដើម្បីធ្វើបទបង្ហាញរយៈពេលខ្លីសូមគោរពអញ្ជើញ Phan គឺជាមូលជាតិទី1 profile 400 មីលីក្រាមដែលផលិតជាក្រមទឹករលាយលឿនបំបត្តិការចិញ្ចាក់លឿនចានេះតាមអត្រាត្រាចានេះគឺជា mechanism របស់អក្សរ Phan ក្នុងការបំបត្តិការរលាយនិងការចិញ្ចាក់ចាជាទូទៅនៅគ្រប់កោសិកាទាំងអស់នៅខាងក្រៅកោសិកាយើងទាំងអស់គឺមានម៉មរ៉ា phospholipid ចាគឺជាសន្ទាប់ខ្លាញ់នៅពេលដែលយើងលេងកីឡាដួលឬមួយក៏មានការយ៉ាត់កាត់គឺអូខេម៉មរ៉ា phospholipid ហ្នឹងគាត់បញ្ចេញនៅអារ៉ាស៊ីដូនិកអាស៊ីតចាហើយអារ៉ាស៊ីដូនិកអាស៊ីតហ្នឹងគាត់បញ្ចេញនៅអង្គពីពីទៀតគឺកុក1និងកុក2ចាកុក1ហ្នឹងគឺ cyclooxygena 1និង cyclooxygena 2ចាហើយកុក2ហ្នឹងគឺជាអង្គស៊ីមួយដែលថាអាក្រក់សម្រាប់ខ្លួនយើងពីព្រោះនៅពេលដែលកុក2ហ្នឹងចេញធ្វើឲ្យខ្លួនយើងមានការរលាក inflammation pain និង fever ចាមានការរលាកការឈឺចាប់នៅក្រៅខ្លួនចាហើយកុក1ហ្នឹងវិញគឺជាអង្គស៊ីមួយដែលថាល្អសម្រាប់ខ្លួនយើងពីព្រោះថាកុក1ហ្នឹងជួយឲ្យ support ទៅលើ platelet function បានថាជួយឲ្យផ្លាកែតជួយការពារទៅលើតួនាទីរបស់ផ្លាកែតបានថាជួយឲ្យឈាមយើងឆាប់កកចាហើយមួយទៀត protect ទៅលើ gastroduodenal mucosa បានថាជួយការពារទៅលើភ្នាសរបស់កាពះចាអញ្ចឹងនៅពេលដែលមានការឈឺចាប់ការរលាកឬក៏ការក្តៅខ្លួនគ្រូពេទ្យគាត់តែងតែចេញបញ្ជាក់បញ្ជាពួក NSAID ឲ្យអ្នកជំងឺប្រើចាពីភ័យនៅពេលដែល NSAID ហ្នឹងគាត់
ប្រើទៅ NSAID នឹងគាត់មាន action មានសកម្មភាពទៅ INP បានតែរាំងស្កាត់កុកធូអត់ឲ្យកុកធូចេញកាលណាកុកធូអត់ចេញបានឲ្យខាងខ្លួនយើងបាត់ការរលាកបាត់ការក្តៅខ្លួននិងការឈឺចាប់ចាក៏ប៉ុន្តែចៃដន្យឲ្យ NSAID នេះវាមិនត្រឹមតែទៅកាត់ផ្ដាច់កុកធូទេវាតែទៅកាត់ផ្ដាច់កុក1ទៀតចាអញ្ចឹងហើយបានជានៅពេលដែលអ្នកជំងឺគាត់ប្រើ NSAID ហ្នឹងគាត់តែទទួលនៅ side effect 2កាត់ឡើងចាគឺ side effect ទៅលើ GI គឺប៉ះពាល់ទៅលើកាពះពោះវៀនមួយទៀតគឺអាជីវមិនរាវចាចាតើអ្វីទៅជាលក្ខណៈពិសេសរបស់អក្សរកូហ្វាយដោយដែលលោកគ្រូអ្នកគ្រូបានជ្រាបហើយថានៅលើទីផ្សារមាន molecule ibuprofen ច្រើនណាស់ក៏ប៉ុន្តែកូហ្វាយរបស់ក្រុមហ៊ុន Mega មានលក្ខណៈពិសេសជាង molecule ibuprofen ផ្សេងទៀតចាដោយសារកូហ្វាយផលិតឡើងក្រោមបច្ចេកវិទ្យាថ្មីមួយឈ្មោះថា Clear Cat Technology គឺផលិតជាគ្រាប់ទឹកនៅពេលដែលអ្នកជំងឺគាត់លេបទៅគឺកូហ្វាយមានការរលាយលឿនស្រូបចូលលឿនអញ្ចឹងមានសកម្មភាពបំបត្តិការឈឺចាប់លឿនជាងឱសថបំបត្តិការឈឺចាប់ផ្សេងទៀតដែលផលិតជាគ្រាប់ត្រឹមចាហើយនៅក្នុងចំណោមNSAID មាន molecule ជាច្រើនទៀតក៏ប៉ុន្តែក្នុង molecule ទាំងអស់នោះមានតែ ibuprofen ទេដែលមាន side effect ទៅលើ GI តិចជាងគេចាបើយើងប្រៀបធៀបទៅនឹង acid mefenamic ឌីក្លូហ្វេណាក់ឬក៏អាស៊ីក្លូហ្វេណាក់ចានេះគឺជាសកម្មភាពរបស់អក្សរកូហ្វាយដែលអ្នកជំងឺលេបទៅរលាយលឿននិងបំបត្តិការឈឺចាប់លឿនជាងឱសថដែលបំបត្តិការឈឺចាប់ដទៃទៀតដូចជាប៉ារ៉ាសេតាមុលឌីក្លូហ្វេណាក់អាស៊ីក្លូហ្វេណាក់ឬមួយក៏អ៊ីបុយប្រូហ្វែនដែលផលិតជាគ្រាប់រឹងចាគឺ conventional អ៊ីបុយប្រូហ្វែនចាសម្រាប់គុណភាពព្យាបាលគឺកូហ្វាយសម្រាប់ព្យាបាលបំបត្តិការឈឺចាប់នៅពេលដែល dysmenorrhea បានន័យថាស្ត្រីឈឺពោះមកពេលរដូវឈឺក្បាលឬក៏ឈឺមួយចំហៀងក្បាលឬមួយក៏ឈឺសន្លាក់ក្តៅខ្លួនឬមួយក៏ឈឺថ្មីដែលត្រូវជាមួយនឹងលោកស្រីដែលជំទង់បណ្ឌិតចានេះគឺជា clinical study មួយដែលឲ្យអ្នកជំងឺក្រោយពេលវះកាត់ថ្មីហើយគឺចែកជា3ក្រុមចាមួយក្រុមគឺគាត់ទទួលទាននៅliquid gel ibuprofen 100 mg មួយក្រុមទៀតគាត់ទទួលទាននៅ ketoprofen 25 mg និងមួយក្រុមទៀតក៏ទទួលទាននៅប៉ារ៉ាសេតាមុល 1000 មីលីក្រាមចាលទ្ធផលនៃការសិក្សាបានបង្ហាញឃើញថាអ្នកជំងឺដែលគាត់ប្រើ liquid gel ibuprofen 400 មីលីក្រាមណាគឺគាត់ទទួលបានលទ្ធផលបំបត្តិការឈឺចាប់ខ្លាំងជាងហើយនឹងលឿនជាងអ្នកជំងឺដែលគាត់ប្រើ ketoprofen 25 មីលីក្រាមនិងប៉ារ៉ាសេតាមុល 1000 មីលីក្រាមចានេះគឺជា clinical study មួយទៀតដែលបង្ហាញឲ្យឃើញថាអ្នកជំងឺដែលគាត់ប្រើ ibuprofen liquid gel ហ្នឹងគាត់ទទួលបានការបំបត្តិការឈឺចាប់ខ្លាំងជាងនិងលឿនជាងអ្នកជំងឺដែលប្រើ acetaminophen ហ្នឹងគឺប៉ារ៉ាសេតាមុល 1000 មីលីក្រាមចាកម្រិតប្រើប្រាស់គឺមនុស្សចាស់និងកុមារលើសពី12ឆ្នាំគាត់លេបម្ដងមកគ្រាប់រៀងរាល់4ទៅ6ម៉ោងម្ដងចានៅនៃការលើទីផ្សារយើងឃើញថា molecule ibuprofen ត្រូវបានប្រើប្រាស់ដោយប្រជាជនរាប់លានអ្នកលើពិភពលោកចាពីព្រោះថា molecule នេះមានសុវត្ថិភាពក្នុងការប្រើនិងមានប្រសិទ្ធភាពផងដែរចានេះគឺជាប្រអប់ថ្នាំអក្សរកូហ្វាយដែលផលិតជាគ្រាប់ទឹកបំបត្តិការឈឺចាប់លឿនបំផុតចានេះខ្ញុំក៏សូមថ្លែងអំណរគុណយ៉ាងជ្រាលជ្រៅចំពោះលោកគ្រូអ្នកគ្រូដែលកន្លងមកបានជួយចេញបញ្ជាក់បញ្ជាអក្សរកូហ្វាយចំពោះអ្នកជំងឺដែលឈឺថ្មីឬមួយក៏ក្រោយពេលដែលកាត់ថ្មីរួចចាហើយនេះខ្ញុំសូមឲ្យលោកគ្រូអ្នកគ្រូជួយបន្តការគ្រប់គ្រងអក្សរកូហ្វាយនេះបន្តទៅទៀតចាសូមអរគុណចា
គូបញ្ជាក់ផងដែរថាសម្រាប់សិក្ខាកម្មដែលមិនទាន់មាន Eco Break សូមមេត្តាទៅសាននិងយក Eco Break ពីកន្លែង registration ពីព្រោះកំប៉ុង line របស់យើងគឺនៅក្នុង Eco Break សម្រាប់សិក្ខាកម្មដែលមានចំណាប់អារម្មណ៍នៅក្នុងការថតរូបគឺអាចអញ្ជើញមកថតរូបបានដោយក្រុមការងារនឹងបញ្ចាំង backdrop ដើម្បីទុកឲ្យថតរូបពេលវេលានេះគឺជាពេលវេលាសម្រាប់បរិភោគអាហារថ្ងៃត្រង់សូមអញ្ជើញភ្ញៀវកិត្តិយសតន្តបណ្ឌិតតន្តនិស្សិតសិក្ខាកម្មទាំងអស់ចូលរួមទទួលទានអាហារថ្ងៃត្រង់ដោយទីតាំងនៃអាហារគឺត្រូវបានរៀបចំឡើងនៅជាន់ទី1សិក្ខាកម្មអាចប្រើប្រាស់ចណ្ដាលប្រអប់នៅខាងស្ដាំដៃដើម្បីទៅទីតាំងអាហារថ្ងៃត្រង់ Ladies and gentlemen, it's time for lunch break.
សម្រាប់គុំចំពោះម្ចាស់ឧបត្ថម្ភសន្និសីទដែលបាន sponsor OMS Import Export និង BNB Implant Supply បរិក្ខារប្រកបដោយគុណភាពនៃសេវាកម្មវិទ្យានិងតម្លៃសមរម្យកម្មវិធីនឹងចាប់ផ្ដើមបន្តទៀតនេះនៅ មួយកន្លះសូមអរគុណ
Please turn to the conference hall at once.